What is the first and foremost function of pathologists in breast cancer management is primary diagnosis. Secondary, we also do the staging of tumors for treatment decision with the size, number of tumor foci, margin, lymph node, etc., etc. But that comes later. First and foremost, the duty of a pathologist is primary diagnosis, for which there are multiple modalities available. The most commonly available in the country even now is FNA, but it is getting superseded by biopsies these days, and of which the most common modality is core needle biopsy. There are multiple other modalities of biopsy, such as vacuum assisted biopsy or large core surgical biopsy. And of course, you always have the option of an open incision or excision biopsy, depending on the extent of disease. But the most common among the biopsies even now is the core needle biopsy. So breast biopsy procedure, this is the various procedures I mentioned. Basically, the size of the material that you are getting keeps increasing as you go from one end to the other. In FNA, of course, you have the smallest quantum of material, and as in the core biopsy, vacuum biopsy, ABBI, and open surgical, the quantum of material increases. So what are the pros and cons for FNA, which is the most common modality available across the country? It is minimally invasive, it is rapid, it is cheap, but still we are preferring core needle biopsy over FNA. Why? Because of the small sample size, and hence very a big likelihood of the sample being unrepresentative. It is definitely less sensitive than core needle biopsy because it lacks the architectural information that is so important to make a diagnosis on histology, and hence it has a high inadequacy rate, and it also cannot distinguish invasive from in situ carcinomas in many conditions. Also, you cannot do IHC properly in FNA. Most of the time, you cannot standardize it properly on FNA. You do not have enough material to do IHC. And also, it does not give any additional material for planning therapy as a core needle biopsy can give. So, its role, if it is not limited, it should be limited in breast oncology. Core needle biopsy, in contrast, it takes care of many of the cons that I have mentioned. It began, somewhere in late 1980s, only to overcome the FNAC limitation and provide a pre-operative diagnosis, as well as spare patient with benign lesions the need for surgical excision. So this is the procedure and method that is used. The needle gauge is around 12 to 14, and this gun is fired inside the lesion, and when it is retracted back, it brings the core of the tissue back with it, and it is processed like other biopsies. So you do not just take out one core, multiple cores are taken out. And as I said, so pros of core needle biopsy is less invasive than an open biopsy, but of course more than FNA. It has better accuracy. You can do IHC, and it provides information for planning therapy. But of course, it comes at the cost of more expense. It is time consuming because histopathology takes more time than cytology. There is chances still of sampling error because still it takes out some amount of tissue, not a big amount of tissue, and it is difficult to perform when the lesion is located in the subareolar or very deep location. Still, in spite of all these cons, the pros far outweigh it, and it has become the standard procedure for suspected cancer cases, and it is considered the gold standard as of now. Now, before you go to the core needle biopsy, first you have to remember that you have to have a good breast radiology at hand when you are trying to evaluate a core needle biopsy. The breast radiology features you should always look for before you start evaluating is what was the radiological features in the lesion type, size of the lesion mentioned, how far, where it is located in the breast, any associated features. Besides that, has any clip been placed, or what is the sampling verification of the breast radiology biopsy report? What is importantly the BI-RADS category? Now, in the BI-RADS category, there are the various BI-RADS score that are given on radiology, and as the score increases, the suspicion for having a malignancy also increases, and it is for this lesions, for especially lesion from 4 to 5, where a core biopsy is preferred for a diagnosis, as the index of suspicion for malignancy is high, and then at one go only the diagnosis can be confirmed as well as the biomarkers can be performed, which can guide therapy. So for large masses, usually the core biopsy is done in a palpation guided manner, and directly it is done in the minor OT. No special procedures are required. However, for smaller lesions or lesions which are a little deeper seated or irregular margins, sometimes guided biopsy is preferred, which can be ultrasound guided, stereotactic guided, or MR guided. All procedures having their own pros and cons. What are the minimal sampling requirements for a core needle biopsy? You need at least 12 cores minimum in calcification, but for mass lesion, even 4 to 5 cores are sufficient. If there is only architectural distortion in radiology, about 6 to 8 cores are generally taken. And if there are heterogeneous lesions, larger samples, larger lesions, multiple lesions, and there is a planning for neoadjuvant therapy and molecular testing requirement, then it is always better to take more cores. Now here it is also important to remember that the number of cores should be ideally divided into multiple blocks so that you have enough material for testing. And when you accept the biopsy, you should receive it with the patient's proper clinical details, mammographic finding, and you should know the site of biopsy. Now, the processing of biopsy is as per the routine histopathology. It should be placed in 10% neutral buffered formalin immediately after procurement. And as per the ASCO-CAP guidelines, we all know that the optimal fixation time is 6 to 48 hours for to get good biomarker results. You must divide the course, as I said, into 2 blocks so that at least you can have multiple blocks for doing ancillary testing if required. And you should always submit it entirely, including any accompanying blood clot. Do not preserve the tissue. Do not save that tissue. It is of no use. You have to make it into a block, and then subsequent block can be chosen for molecular testing or any kind of additional testing. So optimal processing, ASCO-CAP guideline has to be followed. And HE stain. Now some people recommend that at least 3 levels should be taken on a slide. But if your cutting is good, even 2 levels are sufficient. And then if required, additional subsections can be taken depending on your initial screening. And what are the limitations of core needle biopsy? Because you are taking a limited amount of tissue from different parts of the tumor, because of tissue sampling errors or tissue fragmentation or distortion, there are certain lesions which are difficult to differentiate from because of these limitations on core needle biopsy. These include the atypical ductal hyperplasia, which is difficult to differentiate from low-grade DCIS, identifying foci of microinvasion in DCIS, whether it is DCIS versus LCIS, whether it is tubular carcinoma versus low-grade IDC or microgranular adenosis, sclerosing adenosis, basically other sclerosing benign lesions, mucocele-like lesions from mucinous carcinoma, and evaluation of screen-detected abnormalities like columnar cell lesions, papillary lesions, spindle cell lesions, fibroepithelial lesion, vascular. These, because of the limitation of tissue and tissue fragmentation, they can be problems in knowing how to interpret this. So we will try to cover these entities today, and so that we can learn the approach of how to interpret them on core needle biopsy. Basic 3 general principles. Again, as I said, you have to be aware of the clinical and radiological information, obtain additional levels if the pathological findings do not correlate to the radiological findings, and immunostains should be used judiciously when necessary to solve diagnostic dilemmas. And you always have to keep in mind that you have to keep the morphology in mind when you interpret the immunohistochemistry and check whether they are concordant. If it is not possible to render an unequivocal diagnosis on the core needle biopsy because of the limitations as I mentioned earlier, do not overdiagnose. Just give a diagnosis of what level of suspicion you are feeling for the biopsy to get the patient to the next level of management. And I hope we will be covering these management dilemmas with you today. So with this, we start with the case-based interpretation of the cases we have already shared earlier. So the first case is of a 41 female who has a left breast lumps since 6 months with bone pain. There's a large mass. On mammogram, you can see again there's a large area of abnormality involving almost all the quadrants with additional enhancing foci. It was called a Beirad's 5 lesion, and the ultrasound also showed metastatic axillary nodes. So we have, I think we can start with Pooja maybe. Pooja, would you like to describe the slides? Or any of the students who have kind of thought they would like to take the first case can volunteer.
Ma'am, I'm Dr. Sarita.
Yeah.
Ma'am, here in the low power field, we can see 7 cores of fragmented biopsy tissue. I want to on a higher power. You come
Yeah.
at it is showing fibroadipose tissue and some of the cells arranged in cords and single cells, which is admixed with adipose tissue. In higher power, I want some more higher power. Here, individual cells are plasmacytoid to ovoid with moderate to abundant cytoplasm with some cells showing pleomorphism and few of the cells showing prominent nucleoli and cytoplasmic inclusions are noted. In one of the field, we can see one plasmacytoid appearance and mitosis also. Here there is a lobulocentric arrangement of the tumor cells, and there are also scattered Indian file-like appearance of the cells, neoplastic cells.
Very good, Sarita. Thank you. So actually, you have described it perfectly, except I would like to add that here in this slide, you do see a discohesive single cell file pattern. But in this particular images, if you see in these cores, the cells appear to be more thickened. The nests of cells appear to be thickened and almost forming solid areas at places, isn't it? Yeah. In addition to the single file, you also have some kind of thickened trabecular or thickened nests, solid nests scattered here and there. Not all of them are single file kind of appearance. Huh? So yeah, and what about this?
There is a foci of LCIS, lobular carcinoma in situ.
Yeah, so how are you calling it lobular carcinoma in situ and not DCIS?
Ma'am, there is epithelial and myoepithelial, and it is lobular arrangement, not the ducts are involved.
So cancerization of lobules will also look like this.
And that the cells are plasmacytoid appearance.
So if you, yeah, you are right that it is LCIS, but if you see here, see cancerization of lobules by DCIS will also pretty much look like this. But if you see the cells in higher power, you will see that they are all still showing discohesiveness or discohesiveness from each other. Even with inside the nest, they are all kind of maintaining a little bit of space around them. Yeah, so the cells appear they are not cohesive nest inside the in situ component. They are having discohesiveness, and as you said, there are cells that are showing plasmacytoid morphology. Although the nuclear appearance is definitely high grade, I do not see any necrosis here. I think somebody has commented, but yeah. So not absence of necrosis does not differentiate between DCIS and LCIS, but you can see that the cells are all one cell type. But they are still discohesive. They are distending the ducts, but they are discohesive, and they do have, some of them have plasmacytoid morphology. So what kind of LCIS would this be?
Pleomorphic LCS.
And your diagnosis is?
Lobular carcinoma, probably because high grade morphology, so it can be pleomorphic lobular carcinoma.
Great, Sarita. Very good. So when you are trying to approach any, this is just a, a kind of a tumor. First case that we have covered is try to give a tumor case for you to cover all the points that you're supposed to report on the core biopsy. So any other point you would like to add on the core biopsy? What else would you like to report on in the core biopsy? Besides, yes, there is tumor, you would like to report on LCIS. Any other feature? Nottingham grading? Yeah. You would like to report on the Nottingham grading and of course the biomarkers. Okay. Besides that, if you are seeing any additional features, like if you are seeing any LVI, any positive finding or a PNI, you would like to include that. So these are the basic features that you have to report. But whenever you approach a core needle biopsy of the breast, you have to think of in this context. Am I looking at a tumor or if there is no tumor? If there is a tumor, is it a benign or a malignant tumor? Am I looking at a breast versus a non-breast site? Could it be? Is it possible that this lesion that I am seeing is not from a breast site? If you do not keep this in mind, you are going to miss lesions that secondarily involve the breast. Or and then another question you have to keep in mind is whether I'm looking at an epithelial lesion or a mesenchymal lesion. So in this particular case, this was a relatively straightforward case. Of course, we can see a tumor. We can see that it is malignant. It seems to be, of course, of breast origin. There is in situ component, and it is, of course, epithelial in nature. After that, then if the diagnosis is are you thinking of invasive breast carcinoma, no special type, or are you thinking of any kind of special subtype? If you do not think of any special subtype, if you do not keep the various subtypes of breast carcinoma in mind on morphology, you are going to end up missing the rare variants that can be present. So as per the WHO, there are multiple variants on morphology of invasive breast carcinoma. So I will not go through the list, but yes, why is it important to recognize the special subtypes is because distinct morphologies often correlate with distinct clinical outcomes. In this particular case, as you saw, though the areas they were proper single file pattern, and this is what is known as the targetoid pattern, but they were also solid areas. If you get if you get a core in which you are having mostly solid areas, you might miss this targetoid pattern or even the single file pattern, and then you might end up calling it a no special type without any particular testing done for it. And if and as you know that lobular has slightly different prognosis as compared to the invasive breast carcinoma no special type. It is more often multifocal, it is more often bilateral, it is more likely to metastasize to certain sites. So those things will be missed if we do not convey this information right here on the core needle biopsy. So yeah, so in this case we went ahead and we confirmed the impression with doing an E-cadherin stain. And Sarita, would you like to interpret this?
There is loss of E-cadherin, and normal cells are showing the E-cadherin positivity, that is a control.
Yes, always, whenever you're doing and interpreting an E-cadherin, always look for the normal internal control ducts. That will give you a very good idea whether the E-cadherin has worked properly or not. And you will always compare the intensity of E-cadherin with the intensity if you see any in the tumor. Also, you have to, if there is presence of in situ component, always remember that myoepithelial cells are also positive for E-cadherin, myoepithelial. So they are also positive for E-cadherin. So you can see, like you see retained myoepithelial cells in you can see by P63 or SMHC, even E-cadherin will show you at the periphery myoepithelial cells highlighted by E-cadherin, but inside in the in situ component it is completely lost. So this gives an idea that the E-cadherin has worked worked, at least worked. Even if you do not have normal ducts, if the LCIS is there, it will show you E-cadherin at the periphery in the myoepithelial cells. So even now, if we have thought of lobular carcinoma, we have to remember that lobular carcinoma also has multiple phases. You can have alveolar pleomorphic, as Sarita said. You can have solid variants, mixed no special type and lobular. You can have signet ring type, trabecular, mucinous, and histiocytoid variants. Grading of ILC. Now, grading of lobular carcinoma is not as easy as ductal carcinoma, the Nottingham scoring, because you are always starting with a score of 3. By default, the tubular score is always 3, and then you see the nuclear features and the mitosis. And the nuclear score also, it is not, it does not the amount of pleomorphism, because the cells are usually smaller. The amount of the criteria that is used for pleomorphism in a lobular carcinoma are slightly different from the invasive breast carcinoma, no special type. So Rosen's criteria for calling pleomorphic ILC is that you should have nuclear size more than 4 times the size of a mature lymphocyte. You should have nuclear lobation and folding, one or more prominent nucleoli, and hyperchromasia. So these nuclear features are slightly different from what is generally seen in the IBC no special type. There the nuclei are much larger and the pleomorphism is easy to identify. Here if you see, the nuclei are not very large, but the criteria given is it should be more than 4 times the size of a lymphocyte. Now how do you judge that? Here, can you make out a lymphocyte in this section here? Everybody can see this lymphocyte. Now if I take, if I have a dot that I have put the size of this lymphocyte, and this is one nucleus that I am checking, mentally if I'm able to place more than 4 such dots within the tumor cell nuclei, there is space for more than 4, then it fits the criteria of Rosen, that nuclear size more than 4 times the size of a mature lymphocyte. So here you can be very sure that you are looking at a pleomorphic ILC. And also then, as I said, you have to follow in the core needle biopsy, you have to give the biomarkers in the core needle biopsy. And in invasive lobular carcinoma, even the pleomorphic variants, it has been shown that most of the time they will be hormone receptor positive. So if you have a hormone receptor negative lobular carcinoma pleomorphic, that can happen, but it is very rare. Very rarely you can have HER2 positive or triple negative. Most of the time, majority of the time, your ILC, more than 90% of the time, so shown also here in a study from TMH, the invasive lobular carcinoma is going to be hormone receptor positive. So in this particular case also, we went ahead and did the ILC, and you can see that it was ER positive. PR was less but still positive. HER2 turned out to be equivocal in IHC, but FISH confirmed. You can make out that there is no amplification, no increased green signals. So the FISH is non-amplified. So it is hormone receptor positive, HER2 negative. And your core biopsy diagnosis in this case should be an invasive lobular carcinoma, grade 3 pleomorphic variant. You have to give the Nottingham scoring. In addition, you have lobular carcinoma in situ, pleomorphic type, and then the biomarker report. The findings have to be included in the final report. So at this point, I would like to ask Dr. Asavri and Dr. Seema if they would like to give any comments.
I think you have covered everything, Ayushi. What I would just want this resident to like approach, as Dr. Ayushi has said, start with the scanner. You say whether it is breast tissue. Do you think anything there is an abnormality, suspicious for malignancy? Then go for higher magnification. So I think description by Sarita was it was good. I want more participation from other residents as well. I think we can go for next case. Anyone
Yeah.
else want to have any comment?
Ma'am, few questions are there in chat box actually.
Do
Ma'am,
you? I
first,
think we should take questions per case. How do you want to do?
Madam, if some of them you have answered in the chat box, we can move forward, and then whatever is remaining, we can take at the end.
okay.
I
That is
think
what
I
Sarita
couldn't
suggested.
answer each and everything. There are too many.
Okay.
So
Okay.
I think if we start doing all case questions, then I think we'll be too late.
Yeah.
Or should we take a couple of questions?
Madam, I
Like,
cannot see the questions. If you can see,
I'll
maybe.
tell you. See, somebody was asking for risk of spread in FNSC and biopsy. I said no significant risk. And then can we give ERPR HER2 scoring on course where the tumor tissue is very scanty? Of course, you can say positive, negative, but you have to give another a comment that please repeat it on a repeat biopsy or excised tumor. That's one thing I can say. There are other questions like how to differentiate high-grade DCIS and IDC. It's going to be another lecture, I think.
So,
Without markers, can this be called as mixed carcinoma? I think you want to answer that, Ayushi.
no, I would not recommend calling mixed carcinoma only on HE. Mixed carcinoma actually are very rare. In general, the dual this thing that lobular and ductal be present together, it forms a very very small percentage, less than 1% of lobular carcinomas. So if you are looking at something that looks lobular, it was always again also you have to keep in mind the biomarker concordance, that if it is hormone positive, looks lobular, you are having LCIS accompanying the invasive component. So then you can favor a lobular carcinoma if you do not have confirmation of E-cadherin. If you have thinking of that it is looking very high grade and it is triple negative, then rethink your diagnosis before you call it a lobular carcinoma. That is why I pointed out that majority of lobular carcinomas, including majority of the pleomorphic variants, are usually hormone receptor positive. The triple negative and HER2 positives are extremely rare. So always rethink your diagnosis in light of these markers also, if you do not have a confirmation of E-cadherin. There is also another stain, beta-catenin. Now the beta-catenin is more commonly available in most labs, even if you do not have E-cadherin. The problem with beta-catenin is that there is a lot of background staining, but it also gives the same kind of membranous retained positivity. We are not looking for a mutation. It is a secondary loss of beta-catenin that occurs. So membranous positivity of beta-catenin is retained in ductal carcinomas, and it can mimic E-cadherin and show loss of membranous beta-catenin in epithelial cells in lobular carcinomas. So if you do not have E-cadherin, if you have beta-catenin, you can try it in some of your cases and see if it gives a good staining. You can also try that. Madam, would you like to add anything?
And I think there was another question, internal control for E-cadherin, it's benign dubs. That's it.
Yeah.
That should be positive.
So with
I
this,
think.
we move on to the
Ma'am,
second case. Second
Any
case.
other,
ma'am, one
any
question is
comment
also
by
there.
moderators?
Yes, ma'am.
Moderators,
How to differentiate between the high-grade DCIS and pleomorphic LCIS?
So yeah, so as I said, the decisiveness that I tried to show, that is why I particularly showed those areas. So this kind of decisiveness, if you see, ductal carcinoma in situ is going to be in sheets. Even if it is high grade nuclei, it is generally in sheets. If you see this kind of decisiveness, that the cells are trying to keep some space around them and make and a plasmacytoid morphology, this is a very typical of high grade pleomorphic LCIs that you can see the in this thing. So this is a very subtle clue that the cells, in spite of, and it is not on low power, you have to go in high power and look for it, and you have to know that the tissue has to be well fixed, because poorly fixed tissue, the cells are falling apart anyway. So do not mistake that for discohesiveness.
Okay. You want to
Yes, ma'am.
get any comment from Seema, Pallaki, if they are
Yes,
there?
Dr. Seema, if would you like to share that in your management, from your management point of view, would you do anything differently in the lobular carcinoma?
Yeah, so one point I want to stress, I mean, you have talked about it in the beginning, that fixation of the tissue is very important, because we usually face this problem that whenever any outside block is reviewed at our center, it is mentioned that poor fixation, so ER, PR, and HER2 is non-contributory, or we can't comment on this. So this is a very initial step, but very important step, that fixation has to be done properly, because the whole treatment of breast cancer depends upon ER, PR, and HER2 status.
Yeah, very valid point. So this is the first prototypical case of invasive breast carcinoma that we have included, and I would definitely like to underline what Dr. Seema said, that the initial part that I showed, that you have to have this much amount of adequate fixation, neutral buffered formalin, good quality formalin. Please do get that in the lab, because all kind of testing and management is dependent on your fixation. So please talk to your surgeons, please talk to the labs and procure the correct material, so that fixation can be proper. And your interpretation as pathologists, morphology and IHC is all very much interlinked and dependent on fixation. So thanks, Dr. Seema. So if there are no other questions, we move on to the second case. This is a 59-year female who had a left breast lump history since 3 months, and on mammography there was a BIRADS 4 lesion with multiple microcalcifications adjacent to the lesion. So this is the biopsy provided to you, and Harshita, are you there?
Yes, ma'am.
Yeah, so would you like to take this case?
Yes, ma'am. Okay, section study shows breast tissue with multiple with tumor cells arranged in papillary pattern. On higher magnification, papillary neoplasm noted with delicate fibrovascular core lined by atypical ductal epithelial cells. Next slide. On higher magnification, On higher magnification, nuclear show pleomorphism with nuclear stratification noted. Mild to moderate nuclear pleomorphism is seen with hyperchromatic nuclei. And fibrovascular vascular core shows dilated capillaries. So there is loss of myoepithelial cell layer. Ma'am, my diagnosis is DCIS papillary variant.
Okay, so would anybody like to add any other diagnosis, differentials? Okay.
It can be also encapsulated papillary carcinoma. We cannot call this in biopsy. I would call it papillary neoplasm. And we can further categorize with myoepithelial markers or an excision. I would like myoepithelial marker.
Yeah, thanks, Anthony. So now your description was nice, Harshita, except that I would like to add a few things. Okay, first of all, what you see here are very markedly fragmented cores showing a papillary neoplasm. At this power, you do not say that I'm seeing a tumor. Okay, you see a papillary neoplasm, and then you are seeing some other things also. The adjacent breast parenchyma here, and in this there were some areas in which you can see that the adjacent breast parenchyma is also lined by these tall columnar cells. So this is important. Basically, you have to check whether what you are having in the biopsy, are you having only the cores, or are you having also in the cores the periphery of the lesion. So the cores are comprising only of the lesion, or do they also show the periphery of the lesion? And this is very important for the further classification of papillary neoplasm, that you are having not just the cores, you are having the periphery of the lesion. And you have to look for any kind of invasion are you seeing in the periphery beyond the what you are having inside is the intraluminal papillary fronds, but inside in the wall of the lesion at the periphery, are you having any cells, are you having any invasive tumor? So that also you have to look for. Now again, the description of papillary fronds is perfectly fine. You identified that they are basically lined by mostly single layer, but some place stratification is there. There is no infiltration we can see at the periphery and you very nicely identified that there is a lack of myoepithelial cells. You cannot make out any kind of clear cells at the bases here. So these are like tall columnar cells. There is not marked atypia, very mild atypia is there, and the nucleoli are not also very prominent. So here there is a differential of a papillary neoplasm. As Anthony said, there is a differential of papillary neoplasm, and there are multiple entities that can be present in the differential. You can have interductal papilloma with atypia, without atypia, or interductal papilloma with atypia. That is, you can have ADH arising in it, atypical ductal hyperplasia. You can have DCIS arising in a papilloma. You can have papillary DCIS, encapsulated papillary carcinoma, solid papillary carcinoma in situ or with invasion, and invasive papillary carcinoma. So all these form papillary neoplasm of the breast, and it is sometimes on core biopsy very difficult to differentiate most of these entities. You have to know the possibilities, and you end up calling it a complex papillary neoplasm, and you do need some markers in such cases to be able to arrive at a diagnosis. So here you can see that in intraductal papilloma you have to have in these are nice proper circles that I have shown of the papillary neoplasm, but you have to remember that in a core you are going to have a tissue through somewhere in the middle of this. You're not going to have a proper circle, so you have to look for the areas of the periphery as well as areas with the papillary cores. So if you have myoepithelial markers present at the periphery and within the core, then it is an intraductal papilloma. If you have areas of proliferation within the papillary neoplasm, you are having more of solid epithelial multi-nucleation, multi-layer stratification, and it is forming a small area, then it is an atypical ductal hyperplasia. Here you are going to have absence of myoepithelial cells which will be present in the core but not within this area, solid area. And then if it is bigger, it becomes DCIs arising within a papilloma. Again, for both these lesions, because it is arising within a papilloma, you have the myoepithelial cell present within the cores as well as at the periphery. Then you have papillary DCIS. Now papillary DCIS will have myoepithelial cells at the periphery but complete absence of myoepithelial cells within the cores. So it is important, as I said, for you to have periphery as well as the center of the papilla. Then you have encapsulated papillary carcinoma, in which you are going to have absence of myoepithelial cells both at the periphery and at the cores. Then solid papillary in situ carcinoma, you are going to have not a papillary architecture but more of a solid architecture with interspersed vessels, but again absence of myoepithelial cells. Invasive papillary carcinoma, actually you are going to have this kind of papillary fronds, but they are going to be invading the breast tissue and not kind of forming a circumscribed mass. And then you have when you have an encapsulated papillary carcinoma like this, but if you have surrounding tissue, you can see that it is infiltrating the surrounding tissue also, then it becomes encapsulated papillary carcinoma with invasion. And you can have invasive solid papillary when the nests are irregular and surrounding and inflamed. So this is basically just a very small brief introduction to the various types of papillary neoplasms. And let me tell you that of this, only these 4 entities actually look papillary. So to identify that the neoplasm is papillary on a papillary in a core needle biopsy is difficult, because only some of these lesions actually show papillary fronds on the biopsy, and the other lesions can show you some papillary front, but most of the time they are more solid areas. So you have to learn to differentiate these entities, especially the ones which look solid, from other mimics. So in this, how do you approach this kind of complex papillary neoplasm? You do in this case need to put some markers. It will in no straightforward cases, okay, it is easier. But if you have a support of markers, it will definitely help you make a proper approach. And the markers you need are myoepithelial markers as well as two more markers, that is estrogen receptor if you have, and if possible a high molecular weight keratin like CK56. So if you have, as I said, the myoepithelial markers you can use to differentiate if it is positive in the core as well as in the periphery. Then if you have high molecular weight keratin also positive, and the epithelial cells are showing a patchy ER, then it is basically indicating it's a heterogeneous lesion, heterogeneous clonality. There is no monoclonality, so it can be intractable papilloma with or without usual ductal hyperplasia in it. If you have an absence of myoepithelial markers and a diffuse ER, then you are looking at a papilloma with DCIS arising within it. You still have myoepithelial markers at the periphery and at the cores, but you are having solid area which is showing DCIS, which is having diffuse ER. Then if you have the myoepithelial markers negative at the core and positive at the periphery, you are looking at a papillary DCIS. It will also show you diffuse ER and loss of CK56. And then if you have negative in the cores and negative at the periphery, but it is encapsulated, then it becomes an encapsulated papillary carcinoma. It is not encapsulated, then you have the other differentials of solid papillary carcinoma. So in this particular case, Harshita, would you like to interpret this IHC? Anthony, would you like to interpret this IHC?
The P40 is lost on the papillary fronts from what I can see here, and it is also lost on the periphery.
Yes, so it is showing negativity or
Negative.
of P40 at the in the cores and at the periphery.
Periphery.
So you have to interpret in both the areas. You cannot just interpret in the cores, you cannot just interpret the periphery. You need to have both to arrive at a diagnosis. And this other marker, SMHC,
The XMHC is also lost in the periphery and in the papillary fronts. It's just internal control. I think blood vessels are positive for
yes,
SMHC.
yes, perfect. So you will have some amount of blood vessels which can show you the smooth muscle markers, and so you should not mistake them for myoepithelial cells. These are present in the blood vessel. They are not present at the bases of the epithelial cells. So there is absence of myoepithelial cells at the periphery and at the cores. Then what is this?
ER is diffusely positive on all the epithelial cells.
And CK56?
CK56 is lost. I don't see any.
Yes, so it is not showing. CK56 is also a kind of a myoepithelial marker, so it is absent at the periphery, at the cores, and in the epithelial cells.
Yes,
So if we go by this, we are having absence of myoepithelial cells, negative at the periphery, negative at the cores, and it is showing, we saw that it is showing at the periphery some amount of fibrous tissue, but there is no invasion, so it is showing some encapsulation. So can we call it an encapsulated papillary carcinoma? Anthony? Okay, so one thing that in this particular case, yes, it looks like an encapsulated papillary carcinoma in the core biopsy. Now, as I said, I gave you a list of, IHC markers, but, can any morphological clues help? So first of all, if you have marked fragmentation of the core biopsy or the papillae, then it is more likely to be in a malignant condition as compared to benign intractable papillomas, which are usually very, very compact. They do not show, the core do not show that kind of fragmentation as we saw in this biopsy. And then as Harshita pointed out, there is atypia as well as absence of myoepithelial cells identified on high power, while in a papilloma you will see that there is very, you can see that it is much more monomorphic, and you can see clear myoepithelial cells lining the all the papillary fronts. So you can make out that it is bilayered. So these morphological clues can help you differentiate from a papilloma and from a papillary DCIS or encapsulated papillary carcinoma. So Anthony, can we give the diagnosis encapsulated papillary carcinoma in the core biopsy? So actually, we have to remember that in our core biopsy, we are looking at only one part of the lesion, and in the cores are going through one part of the lesion and the central part of the cores or at the wall. But beyond the walls, there might be invasive foci which our cores have missed. So, and it is well known that encapsulated papillary carcinoma may be associated with invasive carcinoma in a large number of cases. So diagnosis of the invasion requires infiltration beyond the fibrous capsule. For that, we have to even if we call it on the core needle biopsy encapsulated papillary carcinoma, we have to put a comment that examination of the entire tumor is necessary to rule out invasive component. So what is the significance of giving this diagnosis? So encapsulated papillary carcinoma versus invasive papillary or invasive carcinoma, it is staged in in situ disease, and it has very low incidence of recurrence or lymph nodal metastasis, and local excision alone or radiation, or if there is a BCS done, then it is sufficient. It does not need an adjuvant therapy. So in this, I would just like to show another case in which you can see at the low power, the cores are showing very, very solid areas. So you will not think of, on looking at these cores, you will not think of a papillary neoplasm at all, right? But then when you go at higher power, you can see that there are some tall columnar cells lining these clefts. You can see these clefts here. And when you go in higher power, you can see tall columnar cells lining these clefts. And even inside these solid areas, you can see some tall columnar cells here and there at the peripheries of this. So this is giving you an indication that this is not a solid proliferation, but there is something papillary happening here. And in this case also there are these scattered blood vessels within the solid areas, as well as I said, clefts with lined by tall columnar cells. So you do your markers for approach of papillary neoplasm, and here in this case you can see that in fact here at the base of one of these spaces, you can see that there is a lot of hyalinization and some irregular nests, and you wonder if there is an invasion here. So when you do your markers, you will see that the SMHC is very nicely retained at the periphery around these solid spaces, as well as around these nests that look like they are possibly invasive, but the myoepithelial markers are retained. And it is showing a heterogeneous ER expression. This is just to show you what a heterogeneous ER expression looks like. You can see these columnar cells as well as the solid areas all having a heterogeneous ER expression. There is no diffuse loss or diffuse positivity. And CK56 is present not only in the myoepithelial location, but also it is present in the epithelial cells. So this becomes a diagnosis of a intraductal papilloma with usual ductal hyperplasia. Now another small lesion where there is a very small lesion which was called Byrad's 4C, small 0.8 to 0.4 centimeter lesion with amorphous calcification, for which the core biopsy was done, and it also showed a very small papillary proliferation, and at some places the proliferation was little bit more solid. You can see that the cores are showing some places papillary and some places little bit more solid areas. So again, and this is the higher power view of the solid areas, some amount of papillae are there, some amount you can see kind of cribriform appearance, little bit monomorphism, little bit solid heaped up appearance. There is no significant ATP or mitosis, but it is definitely monomorphous. So now is it usual ductal hyperplasia or atypical ductal hyperplasia or low grade DCIS? So these are your differentials along with the small papillary proliferation. So what is the difference in the diagnosis? If you say it is a UDH on the core biopsy, patient will be sent back to screening, and on morphology you will see, like I said here, they are seeing a lot of monomorphic appearance. UDH in contrast to the ADH or low grade DCIS has a more of cytological heterogeneity, and it has irregular slit-like spaces. So how do you differentiate based on markers? UDH will show CK56 positivity as I showed in the papillary case, and it will show heterogeneous ER expression. While in contrast, your ADH and low-grade DCIs, they will require surgical excision with or without adjuvant therapy. You will see more of a regular polarized cellular organization and monoclonal proliferation, which is negative for CK56 strong homogeneous ER. So in this particular case, you can see we did these markers, and you can see that the P40 is preserved at the periphery, but inside there is a diffuse ER expression. CK56 is negative. So this basically becomes a atypical ductal hyperplasia or low-grade DCIS. Now, the criteria for calling atypical ductal hyperplasia is either you have a size less than 2 millimeter or more than less than 2 spaces involved, or only a portion of the involved space is forming this atypical proliferation. but it is according to the Royal College of Pathologists, the diagnosis, complete absolute diagnosis of ADH should be reserved for surgical specimen, because this you cannot be sure that in the core you have all the areas of abnormality, and there might be multiple ducts involved which you cannot comment on in the core. So you can call it atypical intraductal epithelial proliferation with a differential of ADH or DCIS. So Anthony, you have some query? No? So yeah, so before we go to the next case, as Asavri ma'am, would you like to say anything?
I think you have covered very well. There were few comments about encapsulated papillary carcinoma, but I think that also you have covered when to call it as and how we cannot, what are the limitations in core needle biopsy for call it as encapsulated papillary carcinoma. So I think if it's covered, then I think we can go ahead with the
Ma'am, one
next case. But
question is
before that,
there.
let me ask the moderators.
Ma'am, one
If
question is there. How to differentiate metastatic PTC in this papillary?
you want to take it.
No, madam, I think that is your field.
This metastatic PTC is very, very rare. First thing, you see any papillary neoplasm in breast, first consider it could be primary. And then Dr. Aisha has nicely explained how to differentiate between benign and encapsulated and invasive. To call something metastatic PTC, we have to have all the features of thyroid, papillary thyroid carcinoma, nuclear features. If you see that, best thing is first go for ISC. PTF1, thyroglobulin, these are and Paxet are definitely a diagnostic of it. But before calling something metastatic, I would first consider breast, and of course, papillary can be seen in other papillary adenocarcinomas. So we can go for ISCs. For breast, it is ER and Kata3 will be positive. Anything else you want to add, Aishi?
We do have another very rare variant, tall cell carcinoma
Yeah.
with reverse polarity in the breast, which can look like PTC also. But again, that is an extremely rare variant, and we would, it is very unusual to have nuclear features of PTC in the breast.
I think tall cell, Preeti Chauhan is asking about for tall cell, though that
Yeah.
Dr. Aisha has already covered.
So,
Any other comments?
Dr. Seema, would you like to add anything?
Madam, I have a question.
Yeah, please.
Will
Please.
you?
Dr. Reno, please
Yeah.
go ahead.
Do we have to give a diagnosis of encapsulated, or we can just put it as a papillary carcinoma, because we don't know? And does a K67 have a role in
So
these?
Ki-67 definitely does not have any role in this particular this thing, because you can in any of these papillary neoplasms you will have it labeled, and there is no defined cutoff to differentiate between them based on the Ki-67. Now regarding encapsulated papillary, yes, in this particular case this encapsulated papillary was given as a possibility because of the marked periphery, where you can see that proper fibrous capsule was there. But
Agreed.
in general, if
There
you are
was a
not able
lesion beneath that, no, in the fibrous one. Nobody talked about that.
Yeah. So that is why in this particular case it was given. But in general, even if you give papillary carcinoma and you advise for excision to rule out invasion, that is also perfectly fine.
Oh, thank you.
The important thing is to advise for excision to rule out invasion, because that sometimes you are not able to have the invasive component on the core, as I showed that you can have invasion beyond the walls of the capsule,
Yeah.
and which you might not be able to pick out on the core. So importance is that if you are having a papillary neoplasm, if you're not able to give a straightforward diagnosis of intrarectal papilloma and you do not have IHCs or any kind of adjunctory support, then even you can give as a papillary neoplasm or complex papillary proliferation, and either advise for this marker or advise for these markers to be tested before going ahead with definitive excision. Asavri ma'am, would you like to add anything?
No, but there was another question for ADH and papillary neoplasm. The criteria are the same like others, like 2 millimeter. size.
So
And but
I
then
guess
it's
either
very, very difficult to call ADH. You want to go explain that, Ayushi?
no, ma'am, please go ahead.
No, you can actually. I would say that DCIS, yeah, definitely. If you have low-grade DCIS like areas, they are very small. Maybe you can call it as ADH or ATPR. But it's better to have a proper area to call something DCIS, or whether it is any ATPR present or not. So yeah, there is no different criteria for papilloma.
Yeah. So third case, next case, 41-year female with a family history of malignancy. You can see that there are multiple people in the family who have uterine cancer, ovarian cancer, CA breast. So definitely we are looking at something, patient is possibly having a germline history. She underwent screening test and her CA 125 was found to be 4,000. And radiology did show a right ovarian mass, but they also found a right breast lesion. The patient underwent an external iliac node biopsy, which confirmed a high-grade ovarian serous carcinoma. But on the mammogram, the right breast lesion, which was further evaluated, was reported as a PIRADS 4B, and the core biopsy was from that lesion. Pimpy, would you like to take this? Pimpy, are you around?
Yes, ma'am.
Yeah.
This is a core by
The little
section
picture
from
is little hazy. I'm sorry for that, but you can just describe what you can see at this power.
yes, ma'am. Section from the core biopsy tissue from breast shows shows abundant fibrous trauma in which irregular nest and solid sheets are there. And in high power, we can see the cells show marked nuclear pleomorphism, coarse chromatin, and prominent nucleoli. And some mitotic figures are also there. There is formation of small glandular and papillary structures also in some areas. Stromal desmoplasia can be seen. Ma'am, according to me, it may be metastatic carcinoma because since ma'am, the
Okay.
family
In
history has
light of the history, you think that this could be a metastasis of the high-grade serous ovarian carcinoma to the breast.
yes,
Is that
ma'am.
right? Okay. Now, anybody, any of the PGs have any different opinion, or do you have any
Yes, ma'am.
differentials?
Yes, ma'am. There is proliferation of the glandular element, but I'm not. And also the proliferation is. I feel like it's well circumscribed. I mean, it's not invading like everywhere. And the stroma is, yeah, it is fibrous stroma, but I'm not seeing much mitosis or like significant cytologic atypia. I'm not seeing. Yes, the glands are angulated, and also I can see some distorted glands, but I can see some whirling kind of thing of the glands also, and I'm seeing sclerosion also in the stroma. I was thinking it might be sclerosing adenosis.
Okay. Anybody else? Any of the PGs have any different opinion? Please do share. So we have some differentials coming in. I think some people have called it metaplastic, some have called it tubular carcinoma. Widely varying differentials are coming. So yes, in this case, if you see at the low power here, now the picture is little hazy, but there are 3 cores, and you can see that there are kind of lobular arrangement is there. There is still some kind of a lobular arrangement here, okay, with the low power. And here, if you see, there is a kind of a lobular arrangement in which all these cells that you are seeing, all the ducts and glands that you are seeing, they're all distributed in a lobulated manner, right? So this kind of lobular arrangement is there, and inside the lobules, now this is, you are going at higher power, and still you are not able to make out the nuclei very clearly. So that means the nuclei are very small, okay? And then you are having this kind of pink cells. Very what kind of cell do you think these are? The cells with abundant pink cytoplasm flowing here and there. So if you have if you have somewhere in the GIT, what would you think these cells to be? Smooth muscle cells, wouldn't you? So some kind of myoid cells, okay? You are seeing some kind of myoid cells at the periphery of these compressed ductal epithelial structures, which are of varying sizes, varying caliber, angulated, but still arranged in a lobulated manner in one aggregate. And you are seeing some kind of larger duct which is branching into smaller ducts. Can you make out? See these larger ducts that are branching into smaller ducts. This again you can see larger duct and smaller branching ducts. So you are having kind of a TDLU type of arrangement, terminal ductulo-lobular type of arrangement. Though it is looking very compressed, it is looking very elongated, it is looking very angulated, and you have, so what you thought is desmoplastic, it looks like it could be a pink myoid appearance, but it is otherwise, it is having a still lobulocentricity, that it appears to be limited to a lobule with a larger duct branching into smaller duct. Now these smaller duct branches seem to be getting pinched out from the larger duct. Very small pinched out appearance of the ducts are there. And in the higher power, again you can see.
Ayushi ma'am, sorry to disturb you, but can you use the laser pointer?
Oops. I think, let me see. No, I'm not able to get the pointer here.
Ma'am, right click.
Yeah, I tried, but it's not.
Ma'am, I think you'll have to full screen, get out of the full screen.
Yeah. 1 second. No, I'm not getting the pointer right now. So anyway, so I will
Yeah,
try
even
to.
I am not finding it. I was.
So anyway, here, let's see if I can show you again. So if you see here, now these are the compressed ducts on the higher part, the ducts that you saw compressed. Now you are having some kind of an epithelial cell at the periphery, but there is a clear space around it. Here also, if you see, there are some clear spaces. Here also, in some of these ducts at the periphery, you can make out some, in these areas, some clear cell at the periphery. Okay, now this is the highest power that I have, and now here you can see that the cells are actually, I don't know why you were calling it pleomorphism and mitosis. In such a high power also you cannot make out the nuclei very clearly, and they are still, some of them are still compressed. So it is basically not having much pleomorphism. It is definitely not having mitotic activity, and all this that you thought is desmoplasia, yes, it could be desmoplasia, but if you see, it has a very pink myoid kind of architecture, and this is causing the ducts to become elongated and compressed. So how would you approach this? You want to, on one hand, I'm having a differential of tubular carcinoma, metaplastic carcinoma, very malignant lesions, and even metastatic, serous carcinoma. On the other hand, Anthony is insisting that it could be sclerosing adenosis. So how would you approach this? What would you like to do to confirm between these differentials?
I would add some myoepithelial markers, no? P40 and SMHC.
So first thing first, you have to do myoepithelial markers to check whether these areas are invasive or not. So he thinks that these infiltrating looking angulated and these kind of arrangement, it is because of sclerosing adenosis, because you are having hyalinization of stroma in between these ducts, which is causing these ducts to become elongated, narrow, compressed. And as I said, you can see a large duct branching off into smaller duct, which is the arrangement of a TDLU. So yes, first thing you need to confirm, and this, yes, it is many times a very common differential of an invasive carcinoma. So in such cases where you have confusion, you do need myoepithelial markers. So in this case, if you can see that P40 is nicely retained around each of those ductular structures, and even here you can see the SMHC. Each of those ductular structures is having a very nicely retained P40 as well as SMHC, and those spindled areas which look like desmoplasia, they are also, you can see these nuclear positivity for P40. So there are also myoepithelial cells which look like those pink cytoplasm elongated cells. They are P40 positive, so they are myoepithelial cells. And what is this ER showing, Anthony? What kind of expression is this?
It's patchy, ma'am. It's not diffuse.
Patchy heterogeneous expression of estrogen receptor. So what have we learned? That patchy heterogeneous expression indicates it is a polyclonal population. It is not monoclonal, so it is likely to be benign, and combined with a retained P40 and SMHC highlighting retained myoepithelial cells are completely around the lesion. The diagnosis is sclerosing adenosis, negative for malignancy. So yes, there was a other strong family history. There was a ovarian cancer history that has misled us into thinking that there might be a concomitant breast malignancy. But there is in this case, we have proved that it is a sclerosing adenosis, which is a very common mimicker of malignancy. But how can you differentiate? Now, I'll just show you another case in which there was a 48 female with a Byrad's 4C lesion, and here out of the 3 cores, you can see that 2 cores are completely normal. There is nothing wrong here, but just look at this third core. Again, you are having, multiple what look like expanded TDLUs, terminal ductal or lobular units with varying caliber, adenosis kind of pattern is there. But what are you seeing in between them? In only part of the core, you are seeing some kind of irregular tubular architecture. Now, is this limited to a TDLU or is it going beyond? Just like the previous case, which was kind of at the edge of the core, but it was in a lobulated manner like a TDLU. Here, actually, in the low par only, you can see that it is not limited to this particular area or TDLU. The cells seem to be going beyond the TDLU. They are even going like from here to here. It is, you can see here also they are extending into this area, they're extending into this area, and they are also extending into the fat. So this is, even though it is at the present at the edge of only one of the cores, you can make out that it is not following the lobulated TDLU architecture that we saw earlier, and it is composed of, on the high power, you can see that it is composed of, again, elongated angulated glands. Yeah, but each gland, they are not like each gland is having a lumen, and it is kind of showing a little bit of, again, you have some kind of desmoplasia. Now, compared to the previous case where you thought desmoplasia, but those were myoepithelial cells, here you can see that there is this kind of myofibroblastic stroma in between, which is different from the one we saw earlier. Okay, so you have glandular infiltration. In between, you have some kind of desmoplasia, and it is not limited to one area or one TDLU. It is going in all direction and infiltrating the adjacent TDLUs also. So, and as compared to the benign parts of this core, where you are seeing the myoepithelial cells, clear cells at the periphery with the epithelial cells in the center, if you see the high power of these ducts, you can see that there are no myoepithelial cells here at all. So, and then there is, of course, as compared, you can see that there is some amount of nuclear atypia, though not very much, but there is some amount of nuclear atypia. So in this particular case, we did again the myoepithelial markers to confirm the presence of invasive carcinoma, and you can see that in contrast to the previous sclerosing adenosis case, there is complete absence of P40 and SMHC, that is absence of myoepithelial markers around these infiltrating tubules. The MIB1 labeling index is low, but we did not expect it to be high anyway, but still it is not, you can see that the normal duct is not having any MIB labeled cells, but the tumor cells, you can find some few MIB labeled cells here and there. And then what helps us very much is, again, you can see that there is heterogeneous ER expression in the normal TDLU, but in these infiltrative tubules, you can see there is a diffuse strong ER expression. Yeah, so this is a tubular carcinoma, and with a BR score of 4 and grade 1. So how do you differentiate benign sclerosing lesion versus low-grade invasive carcinoma? If you have a small gland proliferation, examine on low power to look for lobulocentricity. This is the previous case that I showed you. There is lobulocentricity. There is no extension much beyond the confines of a lobule, but here you can see that it is extending beyond the confines of the lobule. The sclerosing lesion will have some kind of a lobulated contour, which is not be there. There is no lobulated contour here in the tubular carcinoma, and the infiltrative, the low-grade carcinoma will have an infiltrative edge. You have to look for myoepithelial cell layer, use high power field, and if required, of course, you need IHC for myoepithelial markers. And when you use myoepithelial markers, at least use 2 markers, one nuclear and one membranous staining. You can use calponin, SMHC, even CD10, SMA, S100, multiple markers can stain for the myoepithelial cells. ER expression is important, as I said, intense in strong in low-grade carcinomas and heterogeneous in the sclerosing lesions. So, yeah. So this is an important differential. It is many times mistaken on a biopsy. Sclerosing lesion, benign sclerosing lesions can be mistaken. Benign sclerosing lesions, also like something like a radial scar, can be mistaken for invasive tumor. And these are the points to help you differentiate. So, madam, your comments, please.
So I think you have covered most of it, Ayushi. I still think the residents are not participating much. Otherwise, you have covered both benign at home, malignant, uh, the entire spectrum. Now, somebody has asked question about ERPR HER2 positive in DCIS. It can be variable like invasive breast carcinoma. And that's it.
Yeah, so
I don't think any
ERPR
other.
expression, if now the question is that are you trying to differentiate a high grade DCIS or are you trying to differentiate a low grade DCIS from ADH or UDH? So generally the differential of UDH is not a high grade DCIS, it is usually a ADH or a low grade DCIS. So in that context, in that particular context, when you have these kind of differential, high grade DCIS, you can still have, patchy ERPR that does not, that is not the what we are looking for. When we are trying to differentiate between the UDH versus an ADH or a UDH versus a low grade DCIS, then this it is a clonality that is important, and UDH will always be polyclonal, so you are going to have heterogeneous ER, and you are never going to have a HER2 positive. While if you have a low grade DCIS, again you are going to have either you are going to have a diffuse ER. Now, if you have a high grade DCIS with which you are trying to differentiate, you can have completely negative ER and you can have HER2 positive, which you would not see in a sclerosing lesion or a UDH. I hope that covers it.
I think so. Any comments from any moderators? Should we go for next case?
Yes, ma'am.
Yes, ma'am.
Yes.
Yeah.
We don't find, I think, a laser pointer. Somewhere near annotate it should be, but I don't know.
Yeah, I think here I can see. Is it working? Yeah, let's see if it works.
Yes, ma'am.
Yes, ma'am.
Yeah. So, case 4, 59 female with again, the patient already has a diagnosed case of breast carcinoma 4 years ago, which was a triple negative breast cancer. And now she has presented with a lump on the opposite side. So, we are back to Sarita. Sarita, would you like to take this?
So section study shows 3 crores of breast tissue, showing some of the cells arranged in small glands. Next field. These glands few are angulated, showing lined by single layer of cuboidal epithelium with loss of myoepithelial layer. And there is a luminal secretion with few areas showing secretions, showing calcification. There is dense lymphocytic infiltrate, and there is no foci of invasion noted.
Anything you would like to add here?
There is dense
So, what is your diagnosis, Sarita?
Actually, I had two diagnoses, two differentials.
Yes.
First one was microglandular adenosis. But because there was loss of myoepithelial layer and that colloid-looking secretion, I had a DD of secretory carcinoma also, because the history was given was a triple negative breast cancer. So I had two diagnoses.
Okay, yeah, perfect. So Sarita has, I think, described it very well. Now you can see at the low power, we are not having any kind of a lobulocentric distribution. You are seeing haphazardly arranged tubular profiles present from one end to the other in almost all the cores, isn't it? Even in the fat, you are having this kind of tubular profiles present. You are having them of varying caliber mostly, but they are all rounded tubular profiles. There is actually not very much angulation. They are all kind of elongated. Some of them are elongated, but yeah, there is rounded tubular profile with some kind of secretion within them. They are lined by a single layer of cells, columnar cuboidal cells, and if you see, there is not much atypia. The cells are not showing much atypia. Going on higher power also, you can see that there is, yes, as she said, there is absence of myoepithelial cells, and at some places it looks like they are raggedly infiltrating here and there, isn't it? But there is no desmoplasia either. I showed you the previous case in the tubular carcinoma where you could make out desmoplasia. Here there is not much desmoplasia. You can see the cells, the tubules are actually lying back to back in many places, and they are not separate by desmoplasia. Now, what I was trying to show in this particular area was that these areas, you can see that the cells are quite bland, but there were certain areas in which, as compared to the the other area, you can see that there is some amount of moderate atypia. There is not much mitotic activity, maybe one or two here, but other than that, there is some amount of moderate atypia which is not present in all the cores. It is present only focally in some of the areas. You can see that there is some amount of moderate atypia as compared to the other area, and occasional mitotic activity. So this is the higher par view of the area showing atypia. You can again see this kind of single layer of cells with the some kind of mitotic activity, apoptosis, and some amount of, there are no prominent nucleoli, but there is definitely some amount of moderate atypia. So yes, your differentials are good. You have thought of microglandular adenosis. Secretory carcinoma, I'll come back to later. The most common differential, if you have a diagnosis of microglandular adenosis, one of the differential is again a tubular carcinoma. So Sarita, can you tell me why you did not consider tubular carcinoma?
One was dysplasia was not there in this one, and um, secretion is not that seen in tubular carcinoma. That colloid-like secretion usually we see in microglandular adenosis and secretory carcinoma, but not in tubular. And the glands are angulated in case of tubular carcinoma.
Perfect. So here they are more rounded profile rather than angulated. They are rounded, elongated, and rounded profiles are there without much angulation, and there is no desmoplasia. Now regarding secretory carcinoma, how would you differentiate this differential of secretory with MGA?
One is, I don't know, loss of myoepithelial was there.
So loss of
The
myoepithelial
favorite
cells would
features,
be present in
myoepithelial
both
is
the
seen in
conditions,
both
wouldn't it?
features, and they had that history of triple negative breast cancer coming with a secondary thing, and that secretion was confusing for me.
Yeah.
But there was no desmoplasia, so, and not even invasion, so I thought first was for microglandular adenosis rather secrete. But one thing we can do is ETV6
So you are moving on to molecular testing. Would you not like to do anything on IHC first? Huh?
We will do, but that is the molecular.
So what IHC?
We can do yes 100.
Okay. So, okay. So with the differential of tubular carcinoma and MGA and secretory carcinoma, okay, I will keep these three things in mind, and you go ahead and test for myoepithelial markers, and you see that there is complete absence of P40 and SMHC around these ductular profiles, isn't it? And you have basically, so what you're having is absence of myoepithelial cells, as Sarita said. You could not see it on morphology, and we have confirmed it. Now here is the ER. ER is showing complete negativity. So which of these three differentials will you be able to rule out? ER, PR, HER2, all three are negative. So it is triple negative. So which of these differentials, tubular carcinoma, secretory carcinoma, and microglandular adenosis, which of these can be ruled out?
Secretary can be ruled out.
No, secretory is
Secretary
actually
also
negative. Tubular carcinoma can be ruled out.
Tubular carcinoma.
Because most common differential of an MGA in this kind of condition, kind of low grade looking glandular proliferation, your differential is of a tubular carcinoma most of the time. And if you have diffuse ER positivity, but you're thinking of a tubular carcinoma, so that makes for what we call a morphomolecular discordance, that you're thinking of tubular, but your ER, PR are negative, then you cannot have the diagnosis of a tubular carcinoma. So that is definitely completely ruled out. And then you need to think of the differential. And then, as you said, we have done an S100. Now this S100 is diffusely positive. So Anthony,
Yes,
what would you call this?
Microglandular adenosis.
Why not a secretory carcinoma?
Ma'am, secretory can also be strong positive for S100. But morphologically, the cells are very bland looking in the.
So secretory carcinoma architecture is not composed of single tubules, haphazardly infiltrating the breast parenchyma. It is not composed of single tubular structures. It has multi-layering, and the secretions are not just, it has larger branching, bigger cystic spaces. It is not composed of individual tubular infiltrates. Okay. So this is, I do not have a picture of secretory carcinoma as of now with me, but yeah, to differentiate, just to show you again how tubular carcinoma and how the desmoplasia of tubular carcinoma with elongated tubules compared to a microglandular adenosis where you are having back-to-back tubules still raggedly infiltrating but without desmoplasia. And if you have a morphomolecular discordance that you are having, thinking of tubular carcinoma but ER is negative, always go back and look at the morphology. And now the importance being that in a core needle biopsy, if you are giving a diagnosis of microglandular adenosis, you have to remember that most of the microglandular adenosis actually form a precursor for developing invasive breast carcinoma, and then you have to advise that there is some amount of atypia, basically atypical microglandular adenosis also, and it is important to look for the subjacent invasive carcinoma. So an excision of the entire lesion is advised to look for invasion. So yes, it is in this particular case, the patient did undergo a breast lump excision and it showed a one second. Yeah, in this case, it showed a metaplastic carcinoma which was present adjacent to microglandular adenosis. And in this, in microglandular adenosis, when you can also remember that you can have varying amounts of invasion or invasive carcinoma or atypia or DCIS present along with microglandular adenosis in the core biopsy. You have what is called AMGA like DCIS, that is atypical. You have this typical microglandular adenosis that we saw. You can have areas of atypical microglandular adenosis, and then when you have these coalescent kind of ducts without any myoepithelial cells, that is called an AMGA like DCIS. You can have invasive carcinoma, and all of them can be present together in the resection. So depending on where the core biopsy is taken from, you might miss the invasive component, and it's important to alert the clinician that though you are calling it an adenosis, this particular type of adenosis is usually a precursor of invasive breast carcinoma, and so they need to excise the lesion in entirety to rule out the invasive component. It is also important to remember that if suppose it is a BCS that has been done, and this MGA that you see is extending, even typical MGA, if it is extending to the margins or it is close to the margins, then that means that there is a potential for recurrence of the malignancy. So it is very important to excise the lesion in entirety along with any kind of MGA, so that there is no reduced scope of recurrences there. So yeah, I'll stop here. Madam, Dr. Asabri, would you like to add comments on the other differentials and anything about this case?
No, I think you have covered everything. Microglandular adenosis is another pitfall, which may be mistaken for invasive breast carcinoma, that you have explained it very nicely. I see many, even participants, they have called it secretory carcinoma. I can understand because of those secretion, but that doesn't really explain it is a secretory carcinoma. The morphology and the glandular structure is more diagnostic of microglandular adenosis. Now, I would like to ask the moderators, any questions?
Ma'am,
Anything
just
I have
one
a
question is
question.
posted here.
Uh,
Do you discuss this CNBCs with mismatch Biret score and biopsy with radiologist?
Yeah.
One second.
Yeah. So yes, if there is a, definitely there is a very nice article I would like to refer you to on core biopsy, on the radiology aspects of core needle biopsy and rad-pad discordance. So if there is a benign BI-RAD score and you have a benign biopsy, you have concordance. If you have a malignant BI-RAD score like high grade 4C, 4B, and 5, and then that turns out to be malignant, that is still concordant. But if you have at the opposite ends of the spectrum, that completely benign looking BI-RADs, and then you have malignancy, or if you have a completely malignant BI-RADs and then you have benign. So these are the cases where you have to know the differential, because say something like a BI-RADs 5 and you are seeing on the biopsy fat necrosis. Now you should know that fat necrosis can be mistaken for a BI-RADs 5 lesion. So you can talk to the radiologist, and if you tell them it's fat necrosis, they will also review, and yes, it can be considered concordance. If they have called a BI-RADs 3 but you are having a very circumscribed TNBC, so that can also occur, that TNBCs can sometimes be, that medullary like can be circumscribed and it is concordant with sometimes a BI-RADS 3 also. So these kind of things are not actually discordances, but actually if you have something like an infiltrative tumor, when they have called a BI-RADS 3, that is a discordance. And the other way around, when they have called something like a BI-RADS 5 and you are seeing almost normal breast, you're not able to explain the BI-RADS score, then we do pick up the phone, talk to the radiologist, try to figure out. We also do, something very important, we try to rule out mix-ups. That is, on the same day any other biopsy has been taken, is there any kind of discordance in any of those? So we try to eliminate one by one any kind of possibilities that you have, is there in the, to try to explain the discordance. And again, I emphasize it is very important to know the radiological findings when you interpret the core biopsies, because there are chances of these kind of discordances, and if you pick out those discordances, then only you will be able to solve. Actually, I had a very good case in which this kind of situation was there, BI-RADS 5, but it was a benign, completely benign breast tissue. It was not explaining the BI-RADS 5 at all. There was no fat necrosis, nothing, any kind of mastitis or anything that can be mistaken for BI-RADS 5. And on that case, we did call up the radiologist, who said that the biopsy is possibly not a guided biopsy, it's a blind biopsy. So they have possibly missed the lesion, and a repeat guided biopsy definitely picked out a nice invasive breast carcinoma. So yes, you have to be on the lookout for these kind of RAD-PAD discordances. In this particular case also, like if it was a I think BI-RADS 4B lesion, but if we are reporting it as microglandular adenosis, which is actually a benign lesion. So we have highlighted that yes, though it is showing microglandular adenosis, there is atypia within it, and there is likelihood that there is invasive tumor. So they did go ahead and try to excise the entire lesion, and then they pick out the invasive carcinoma. So yes, that's a good question. RAD-PAD discordances should definitely be looked into before issuing the report.
Any
Thank
comments by chairpersons?
Yeah, I would like
No,
to highlight.
it's related to the previous question. Question. So you've answered it, because how do we report a microglandular adenosis when there is a definite lump, and what happens when when it finally comes to as a cancer, as a malignancy? Do we have a problem? Does the pathologist have a problem? The one who reports the biopsy, core biopsy, does that pathologist have a problem? They have to be careful in reporting. That's what I'd like to bring out.
Yeah, you're right, madam. So here, as I said, in this particular case, we did say it is microglandular adenosis and everything, but we highlighted that given the ATP, it is essential to evaluate for an invasive carcinoma. So this is what we would report in any microglandular adenosis that we see, regardless of the presence of atypia, that we need to correlate with the radiology, and if there is a bigger lump, we need to excise it completely to rule out invasive carcinoma. And given the fact that many of the microglandular adenosis, as high as 27%, of microglandular adenosis can give rise to TNBCs. So it is very important to advise for an excision of the microglandular adenosis, including absence of microglandular adenosis at the margins, so to avoid a recurrence of the same. And also you can also do P53 IHC. We've done in our cases, and we have seen that you can see this mutant type of P53 IHC in the microglandular adenosis as well as in the invasive carcinoma. So that is also a harbinger of high grade malignancy somewhere in the tumor in the breast, as well as in many of our cases we have, especially similar to this case, we have found that there can be an association with family history or BRCA mutations, and there is a higher chance of progression in such cases. So you can also advise or check for family history and or history of BRCA mutation in the family. So in this particular case also, germline testing confirmed that there was a BRCA mutation. So there are lots of implication of this diagnosis, and it is you need to be aware of these implications. I don't think the pathologist who has given MGA should get into any trouble for it, except that you need to know that many of the clinicians are not aware it's a rare entity.
Yeah.
So they need to be aware that you have called it adenosis does not mean that they can leave the patient alone. It needs to be excised. So that maybe you can have a conversation with the surgeon.
I think
that
we'll
has
have
called
to
it.
communicate it not on by the report. We have to orally communicate it to the surgeons.
Yes. Many of them are not aware of the implications.
Yes.
So excision is essential, but I think Seema wanted to say something. Seema,
Yeah,
do you
ma'am.
want to?
Yeah, I want to tell this to students that it is very essential to understand and look at the morphology of any lesion that is being given to you. In today's era, everyone is moving towards IHCs and molecular testing, but morphology is very, very essential, and that will only guide you what kind of lesion it is.
Thank you, Seema. I think that's well summed up. Any other comments from any chairpersons or moderators? You want to
I
say
think
something?
we have covered all the questions in the chat box for now.
Okay,
So
I
we can
think then,
proceed to the next. Yes, ma'am.
Ayushi, maybe you want to stop
Yeah,
sharing, and should I start sharing?
Yes, ma'am, please.
I think it's coming. Okay, let me try this way. I think something is wrong. Do you see that? Ayushi, can you see that?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay, then I think let me know how many residents are there actually. I see Anthony, Harshita, Sarita, Pooja, Pimpi. Anyone else I'm missing? And who has not answered yet?
No, ma'am, I think we have these 5.
Okay, I think I'll
I can't
start with
unmute myself.
anyone else? No,
No,
I think
ma'am.
I'll start with either Harshita or Pooja.
Okay.
Yes,
Ma'am, the histological section show multiple
one
fragments of the
second,
tumor
one
tissue.
second. I know what I have a problem here. Just give me a minute. It's coming directly to this one. Okay, so let's start with this. This was a 42-year-old female with a left breast lump, 7 by 6 centimeter, 2 o'clock, and mammography showed linear calcification, and it was on USG. There are prominent solid ducts seen from 9 to 3 o'clock position. It was BIRAD 4C. So what do you see here? Who wants to say? Pooja?
Ma'am, here in this section, there are multiple fragments of the tumor tissues are shown, and stroma is also present.
So tumor means what do you see here? Do you see normal breast here anywhere?
No, ma'am.
Okay, now here we have some higher magnification. Tell me, describe it out. What do you see?
The tumor cells are arranged in the form of the nests and sheets, and at some places glands formation. And in the one area, there is a necrosis also present.
So do you think there is a specific pattern here? I am
No,
focusing
ma'am.
on this area. I am focusing on this. What do
Ma'am,
you see
here
this?
the ductals arranged in the form of the nest, but they are not showing the invasive. Well, in one area, they are showing the invasion. This.
Can you tell me where exactly you think there's invasion? Is
Yes,
this,
ma'am.
this one?
Yes, ma'am. In the stroma, they are showing the tumor cells, and also the same cells are showing in the lobules, in the ducts.
So these cells and these cells, they are similar. Do you think they are just
Yes, ma'am.
proliferative changes, or like Aisha madam has just shown you some adenosis cases, right? Benign ones. Do you think they are different from them? Yes or no?
No, ma'am.
What about this?
Ma'am, this is an comedonecrosis.
So do you see comedonecrosis in any normal or benign condition?
No, ma'am.
So that's what I'm asking you. So when you see this proliferation in the ducts, outside the ducts, there is a lot of necrosis. What do you think about nuclei? Do they look any normal nuclei to you? As Dr. Aishi said, compare them with the rest of lymphocyte nuclei. How do they look like?
Ma'am, they are large and they are showing pleomorphism.
Right, here you see large pleomorphism. So you think they are atypical, right? What do you see here
Yes,
at the periphery here? Can anyone tell
ma'am, they
me?
are myoepithelial cells.
So can you describe myoepithelial cells, how normally they look like?
Ma'am, elongated cells, slender shape.
Anyone else want to say something? Harshit, you are Pooja, right?
Yes, ma'am.
Harshita, Sarita, Anthony.
Ma'am, normally a myoepithelial cell will be flattened or epithelioid. Sometimes they can have a clear cytoplasm as well.
Exactly. So basically, when you have these distended ducts, then you will see the myoepithelial cells are flattened. But if you see normal breast parenchyma, many times they have like epithelioid appearance with more clear cytoplasm, right? Okay. Pooja, you tell me, what about this area? How do you describe this area?
Ma'am, here the tumor cells are invading into the stroma and the cells are round to oval, showing nuclear pleomorphism and with a scant amount of the cytoplasm.
Okay. So now you have come to the diagnosis that this is invasion. What next you will do? In this biopsy, what next will you do?
IHC.
Why ISC? Not every medical college or every hospital has ISC, right? In a clear, of course, I'm going to show you ISC. If they are there, you always use them. But do you think morphology is good enough in this case? Anybody has any
Ma'am,
doubts?
I think why can't this be an epithelial displacement, ma'am? Because they are looking very similar to what is in the inside the DCIS, and I'm not seeing an infiltrative pattern. I'm seeing inflammatory reactions around it, so it could very well be a epithelial displacement.
I like your question, Anthony. See, to call something epithelial displacement, you will have, why should there be, right? Was there any FNAC done earlier? We don't think so. I don't see any FNAC track. Now, this kind of reaction you see, all of you remember, this is usually the reaction for invasion, okay? So to call something epithelial displacement, which is quite a rare one, not very common, we don't have any FNAC or prior biopsy tract. So I will not call it. The nuclei look the same. So to me, it's more likely going to be invasion. Okay. So now once we have decided that this is invasion, what is next? What should we do? Do you think we should measure the size? And how do you measure the size on microscopy? Anyone has any clue? And why size is important? I want some answer from residents. If you want to measure the invasive focus, how do you measure it? And like a simpler way. Not every time we are going to mark it and measure it. Is there any simpler way to measure it? And why it is important? Pooja, Archita, Anthony. I'm
Ma'am,
talking
on
about
the
invasive, not
microscopy,
ADH. I'm not talking about ADH or DCS. I saw some messages, but we are talking about invasive carcinoma, size of invasive carcinoma. Why it is important to measure the size?
Ma'am, usually without using the caliber or the scale, we usually take one high power field as 0.4
0.4 to
mm.
0.5. 40x is 0.4, almost 0.5 it
0.4.
goes.
Okay.
And 20x will be like almost 1 millimeter, right?
Yes, ma'am.
The
So if
diameter of 20x, so 20x
20
if
is
we use 1 millimeter. So what is the cutoff here and why it is important?
if it is micro invasion, it should be less than 1 mm.
Okay, so up to 1 mm or less than 1 mm is Microinvasion.
Microinvasion.
And does that matter in core biopsy? Yes or no? Any invasion anywhere, core biopsy or outside.
It will matter because we have
It is
to
exactly.
stage the tumor.
So in core biopsy, let me tell you, in core biopsy, you are not going to stage the tumor, but identification of any invasion and this if it is microinvasion, mentioning that microinvasion is important in core biopsy. It's possible that you get later on the excised tumor, you may not find any invasion at all after extensive sampling. So this is the only focus, and then we have some evidence that there is invasive carcinoma, right? So this is our invasive carcinoma. What is your diagnosis?
DCIS with foci of invasion.
Foci of invasion, or what we discussed just now?
Microinvasion.
Microinvasive. So approach to diagnosis, how do you do that? So you are talking about, somebody was talking about ISC, right? What ISCs we do?
ERPR HER2/neu.
Do we have to do ERPR HER2 directly on this? We have to. Any invasive carcinoma, okay? But to confirm invasion, somebody was asking, we'll do ISC, right?
Myoepithelial marker.
So what are the myoepithelial markers, Anthony?
P40, SMHC, SMA, P63.
So as you see here, you see this ducts DCIS. You can see P63 is nicely maintained, but you see those small foci of invasion here. Can you see the laser pointer?
Yes.
Where you don't see any P40, right? So P40 is lost around the foci of microinvasion. This is SMSC, right? Similarly, SMSC, you can see SMSC at the periphery of DCIS, but lost around foci of microinvasion here, right? So if you are in question, you can always go for ISC, but most important here is identification of invasive focus, comment on that, and if it is microinvasive, comment on the microinvasive focus. There is one more ISC usually in case of microinvasive carcinoma, which can be helpful. When there is extensive, we call this as extensive DCIS with microinvasive carcinoma. And for these cases of extensive DCIS, usually they are HER2 positive. Can you see here? HER2 is nice, strong, intense, membranous, complete. And here is our invasive carcinoma. You can see the scattered cells. So this is typical, and many times we use HER2 to identify invasion. That can be a very good marker to identify invasion, although you can't use it in too many sections. But if you are suspicious or you want to confirm it, HER2 is another marker that can be utilized. You can see here. Can you see this invasive carcinoma here? So this is a microinvasive carcinoma with DCIS, extensive DCIS. And the diagnosis of invasion is essential in biopsy. So what is the further treatment? Anybody knows? Is there any change in treatment if we call it DCIS versus invasive carcinoma?
Yes, ma'am.
What is it?
Invasive carcinoma, usually they will check for hormonal status.
Oh, that's a good idea. Good point you brought it up. So invasive carcinoma, exactly, we have to do not only hormonal, biomarkers like ERPR, HER2. That's true. That's our job to give them, right? We have to do these markers and comment on that. What about clinicians? Are they going to change any treatment if I call DCIS on core biopsy versus invasive carcinoma? If I miss any, or if the biopsy doesn't include any invasive carcinoma, will there be any change in treatment? And what is the treatment, by the way?
Mastectomy. Invasive, it will be
It's not always mastectomy. I would say excision with wide local excision or mastectomy. So is it for invasive? For DCIS, they don't do anything?
High-grade DCIS usually like
Any DCIS they
lumpectomy.
will do. Any DCIS they will do. Okay. If you're calling it DCIS, nobody wants to. It's a precursor lesion. Nobody wants to keep it in the body. Okay. So
Breast
DCIS
cancer.
will be excised always. There will be adequate margin. It depends. Like if you're calling ADH and all, they may not want to, but DCIS definitely. Okay. So this is, we are calling it extensive DCIS with microinvasive carcinoma. What is the importance of it? So when you have any microinvasive carcinoma, there could be multiple foci. Each invasive focus should be less than 1 millimeter. None of them should be more than 1 millimeter. Even if it is single focus more than 1 millimeter, it becomes T1A. The T stage is T1A. Now, whenever you see this microinvasive carcinoma, there is extensive DCIS around it. And this DCIS is usually high-grade DCIS, may show some comedonecrosis, may show some multicentricity. So these are likely scenario for any microinvasive carcinoma. It tends to be associated with high-grade DCIS and small foci of tumor cells, as you explained or described, they are seen invading through the basement membrane into the surrounding stroma. What is important to identify is the reaction, stromal reaction to the tumor cells, invasive tumor cells. Then if you see LCIS, it is less likely to be associated with microinvasion, okay? So that is one thing we have to remember. My markers we have covered, either we can use myoepithelial markers. If it is HER2 positive DCIS, we can use HER2 new in some cases. What about the prognosis? If it is only microinvasive, it is excellent prognosis. Now remember, if it is microinvasive or any invasive carcinoma, you have to do ERPR HER2. If you find it on biopsy, you do it on that. If you find it on, if you call it something DCIS on biopsy and find microinvasive or invasive carcinoma on subsequent resection, you have to do on that invasive carcinoma ERPR HER2. Okay. And survival, if you consider, it is intermediate between DCIS and small invasive. Small invasive means T1A, T1B, this type of carcinomas. So this is about microinvasive carcinoma. We got the subsequent mastectomy of the same patient because it was a big tumor, right? We said it is 7 by 6 centimeter. What do you see here? Anyone wants to, I know this was not included, but you can just describe, right? You have understood now. What are these areas I'm pointing out?
Inside to
Sarita,
carcinoma.
Harshit,
With
these
necrosis.
are inside to, right? DCIS.
Yes, ma'am. Yes,
What
ma'am.
type of DCIS you want to say?
Comedo type because central
So
necrosis.
tell me one thing. When we say comedo type DCIS, what exactly is included in comedo type of DCIS? There are certain parameters when you call it as comedo. So for DCIS, let me tell you one thing, all of you. Whenever you describe the DCIS, there are 3 parameters you have to describe. One is architecture, but most important is what is the nuclear grade, which is either low, intermediate, or high. And third thing is whether necrosis present, absent. If necrosis is present, whether it is focal punctate or it is comedo type. Now tell me, anybody knows what is comedo type DCIS? Comedo DCIS has particular morphology. If you see here, what type of architecture is, what type of DCIS it is? Anthony, would you call it solid?
No, ma'am. There is a central
Still
necrosis.
it is solid. Central part is destroyed. But you can get sometimes cribriforming. But when this is kind of solid areas, when we have so much of comedo type necrosis, now what is the comedo type necrosis? Do you know?
It is a
These are
central
basic
necrosis.
things. Right? Tell me.
It is actually like a comedon. It will be in the center. The necrosis will be in the center because of lack of blood supply. There will be dead cells and there will be cardioractic debris in the center of the.
So something that resembles like acne, right?
Acne.
So this is the central portion is comedo necrosis. So there are 3 things. Usually it is a solid type. Nuclear grade is high and the necrosis is comedo type. So all this went together, that is called comedo necrosis. So this is, we have a lot of DCIs, right? What about this area? Something we have marked. Any comment on that? And yes, come on, go ahead, Sarita.
Invasive component.
It is invasive component. And what do I say? What do we say here?
5 millimeters.
What is the length?
5 mm, 0.5 centimeters.
0.5, a little bit more than that, or 0.5. So what do you think now? Is this still microinvasive? No, right? So now if it is a little bit more than 5 mm, we'll call it as T1B tumor. So that is why it is important when even if we call it as micro-invasive on core biopsy, we have to take multiple sections in mastectomy on the main tumor when it is excised. Make sure you measure the largest invasive tumor size. There could be multiple invasive foci. Measure the largest invasive tumor size, and that will decide the T size of the tumor. Is that clear to all of you? Here you can see it, right? Any questions? Anything you haven't understood?
Ma'am, do we
Here I-
have to report DCIS with foci of invasion in core biopsy, or should like micro-invasive we can give it in core biopsy, or should we
core
wait for
biopsy, core biopsy will report both. You say there is microinvasive carcinoma and there is DCIS. And DCIS you also give. Microinvasive carcinoma, when you say you comment on nuclear grade. Remember that focus is too small to give modified Bloom-Richardson score. But you can definitely comment on the nuclear grade, whether it is high nuclear grade or group grade, nuclear grade 3 versus 2, right? It's rarely it's going to be 1. It's going to be either 2 or 3, almost always 3. So comment on nuclear grade, comment on size of the microinvasive carcinoma less than 1 mm, and comment on the DCIS, what type of DCIS it is. Is that clear how to report it?
Yes, ma'am.
So again, Suhas is asking how to measure the invasive component. We have already answered that. Usually it is the 40x is 0.5 diameter of 40x when you look into the 40x. When you look into the 10x is usually 2 millimeters diameter of the field. Okay, here I'm going to show you HER2 again. We talked about HER2. We repeated HER2 because we found the larger focus here and we wanted to make sure it is still HER2 positive. And it is HER2 positive score 3+. Is that clear? So before I go to the next case, Aisha,
Ma'am,
do you
you
want to
can
say something?
Yeah, just one thing to add that when in a core biopsy you have called DCIS or a DCIS with microinvasion and you get the excision of the specimen, you have to be sure to sample the area of abnormality extensively, because as we have shown, you can have in what has been called on biopsy only DCIS, you can have foci of microinvasion, but you will miss them if you do not sample the DCIS extensively. Similarly, even if we have called microinvasive on the core biopsy, you can have larger foci of invasion in the main tumor mass, which again, if not sampled adequately, you can miss. They can be focal, they can be multiple. So if you sample only take 1 or 2 sections that okay, it was just called DCIS, you are going to end up missing foci of microinvasion as well as maybe foci of larger invasion. So please be sure to sample what has been called DCIS on the core biopsy extensively.
So that's again, thank you, Aishi, for pointing out. So what we usually do in excised tumor, so until we find some invasive focus, we will submit a lot of tumor sections. Usually you tend to find one invasive focus. And in spite of submitting more section, if you don't find, you can say that it is a DCIS. But if it is a 4 and 5 centimeter of DCIS forming mass, then it's more likely to harbor some kind of invasion, and we don't want to miss that. Other comments, I think Dr. Renu wanted to ask something.
Dr.
Any
Renu has
comments
a
from the
question.
Yeah, I
chairpersons?
wanted to ask a question again here.
Yeah.
In how much, what would you suggest be the number of samples per centimeter one, or is that adequate or more?
There is
When you
no,
say
I
extensive,
would say
is there any guideline?
no
Is there
guidelines.
any?
So yeah, that's a good question, Dr. Renu. There are no
Thank you.
guidelines as such because we are not going to stop if I find, suppose it's a 5 centimeter tumor, okay? I submit initial 5 section, but gross examination definitely important. So gross examination sometimes shows you nice invasive focus, even if it is small. So if you slice the specimen tumor thinly, and then you look at some areas where it looks like infiltrate, you get those areas. If it is all
Okay.
gritty, submit at least 5 to 6 sample specimen section initially, but sometimes we go beyond that. And there is no threshold as such until we are satisfied. So sometimes it can be 10, 12 sections as well. So usually we find at least one focus in that. Rarely it happens that we don't find any. So are we going to submit entire 7 centimeter tumor? No. But
No.
yeah, we try our best to find out some invasive focus. Yeah, Kajal, you wanted to say something?
Yes, ma'am. Like in this case, in core biopsy, this focus was around less than 1 mm. So in such
Yeah,
cases, do we need to take serial sections to check in case of
not
biopsies?
necessary. In biopsy, it's not necessary. All you do is ERPR HER2.
Okay.
So don't go for serial section. If it is confirmed, do ERPR HER2. If you want to do myopithelial markers, that you can do. No need to go for serial section. I will ask for serial section only when there is confusion whether there is invasion or not.
Yes, yes. Thank you, ma'am.
Any other question? If not, I think I want to go to next
Yes,
case.
My query also.
Yeah. Let me know if there are any other question. Otherwise, I'll go to next case. Kajal,
Ma'am,
how we are doing with time? I think we are already up to 9, but I think
9.
there are
Yes, ma'am. Yes, ma'am.
Can we go ahead with
Ma'am,
next
there are no
cases?
current questions in the chat box, so we can proceed to the next case.
I think let's go with the next cases because those are important equally. So coming to the case 6, 61-year-old female, left breast lump, 4 months duration. It is a 4.5 centimeter lump with lymph nodes palpable. It was well-defined, extensively calcified lesion. Remember that. And it was Barrett's 4A. And we got a biopsy from the lump. Now, who wants to describe that? Either you, one of you, volunteer, or I have to call the names. Pimpy, you haven't spoken for a long time, for a while. Are you there, Pimpy?
Yes, ma'am.
Pimpy, you want to
Yes.
describe this? Can you describe?
Section from the core biopsy shows in the low power shows a tumor which has replaced a whole normal breast tissue.
Good. That's what
We
is
can-
more important, that you don't see any normal breast tissue, right? Go ahead.
Yes. We can see solid nest or solid sheets of tumor cells, and there we can also see biphasic pattern, like there is mesenchymal component also, and ma'am, it may be a mesenchymal component or an epithelial component.
So you are going in right direction. Again, this is higher magnification. I am pointing out this area. What is it?
Ma'am, osteoidea, but
Correct.
chondromyxoid.
That is the
Yes.
mesenchymal component.
Yes, ma'am.
And you said there is probably epithelial component.
Yes, ma'am.
Are you sure if there are any epithelial cells? Any suspicious looking? I'm pointing out here, right?
Yes,
Do
ma'am.
you think these are epithelial cells? What is this?
No, ma'am, these are these are chondroid.
This is chondroid area. What about these cells?
They're lacy like, ma'am. These are
And this area, this pink area with nuclei. You see these clusters?
squamous.
So they look like epithelial cells, right? Look at
Yes,
this.
yes, ma'am.
So as you said, these are kind of little bit squamoid looking.
Yes.
Okay. So can you summarize the points that you have described?
Ma'am.
Here again.
Hello, ma'am.
Go ahead.
Ma'am, it is a tumor which which has replaced a whole normal breast tissue, whole tissue with a biphasic pattern of epithelial and mesenchymal component. Tumors are arranged in solid sheets, nest, or fascicles, and their osteoid and chondromyxoid areas are also seen.
So what is your differential here? Or what, can you come to any diagnosis? Do you need any ancillary studies? Ancillary studies means ISC or something?
It may be a metaplastic carcinoma test.
Is there any particular name for those other areas? You said osteoid chondroid areas. What do they call them?
Yes.
What is it called as? Anyone?
Mesenchymal differentiation.
Anthony. Yeah. What did you say, Anthony?
Mesenchymal differentiation. Metaplastic
Or
heterologous
mesenchymal differentiation, right? So here I want to show you the ISC. Of course, it was clearly epithelial appearing component, but we were not sure about this. You see this stromal looking cells. So they are negative for A1, A3, but TRPS, which is another marker, which is positive in epithelial looking component as well as in mesenchymal component. So diagnosis is metaplastic breast carcinoma with heterologous mesenchymal differentiation. Now you tell me, what exactly is metaplastic breast carcinoma? What do you find in metaplastic breast carcinoma? Why it is anywhere any metaplastic carcinoma? Yes.
Other than metaplasia from the normal
Normal means whatever is the
invasive.
native tissue. Like here, breast is what type of epithelium? It is glandular.
Glandular.
So any differentiation away from glandular is all metaplastic, right? So even squamous is metaplastic. Any mesenchymal is metaplastic. Is that clear to you? So what are the types of metaplastic carcinoma in breast? I have written here. Start reading.
Epithelial.
So it could be epithelial, mesenchymal, or mixed. Okay. It can be monophasic versus biphasic. When it is monophasic, usually it shows only mesenchymal features. Biphasic, it can have mixed epithelial, adeno and squamous, or it can have epithelial like adeno plus mesenchymal, or that means sarcomatoid or spindle cell features. Is that clear to you? Now, whatever we saw today, this case, what type of it is, what type of metaplastic it is? Tell me now. Where does it fit?
Biphasic.
Biphasic and
Mixed.
mixed. It has adenocarcinoma component. It has mesenchymal component in the form of osteoid and all, and plus it has some squamous component also, right? It can be a mixture of anything, right? So this is how the metaplastic carcinoma can look like. Now tell me, who wants to comment on this? You get some biopsy like this and this kind of cells are there. What is your differential? This wasn't included, but I want you to quickly comment on this. What type of tumor you want to say?
Spindle cell neoplasm. Like
Loudly?
spindle cells are there, no? So
Yeah,
initially
correct.
it is spindle cell
cells.
neoplasm.
Spindle cell tumor. Now, what about the nuclei? How do you find this nuclei?
They are
they normal, benign looking, or
no,
atypical?
not benign looking, pleomorphic.
Pleomorphic. So, do you think it's a malignant?
Yes, ma'am.
Yes, ma'am.
So, tell me something like, what is the differential diagnosis of malignant spindle cell neoplasm in breast? Tell me.
Malignant.
Yes. Good.
It could be a metaplastic also, ma'am, with a pure mesenchymal component.
Yes, sarcomatoid or pure mesenchymal component is one. Second, what else? There is one more tumor. Commonly we see that. Commonly it's not uncommon. Now, that is another thing. Okay, you want to call it sarcoma? Yes. Sarcoma is one possibility. Primary sarcoma of breast, and usually primary sarcomas, usually they are angiosarcomas. What else? There is another tumor you are missing.
Malignant phyllodes also.
Malignant phyllodes. Don't forget that. Malignant phyllodes can have stromal overgrowth, and in biopsy you may not get any ductal components at all. Okay. So that's why you need to consider all these possibilities. Now, is there any ISC that would help you? Will you do any ISC on core biopsy? And if you want to do what ISC? Come on, fast. Aren't you hungry? ISC, we're talking about sarcomatoid carcinoma. We're talking about phyllodes tumor. We're talking about sarcomas. Sarcomas is kind of rare. First, let's rule out sarcomatoid carcinoma. What ISC will you do for sarcomatoid carcinoma? Harshita, Pooja, Anthony, A1, A3. Okay, A1, A3. So if A1, A3 is positive, what is it?
Sarcomatoid.
Sarcomatoid. Fine. So A1, A3 is sarcomatoid carcinoma, but again, A1, A3 when it is positive on many cells. If it is very focal positive, remember even phyllodes tumor can show some epithelial differentiation. Okay, some positivity for A1, A3. So a diffuse positivity or in many cells or patchy areas of positivity will be more likely to be sarcomatoid carcinoma. Will TRPS1 help? No. TRPS1 is a marker which can be positive in metaplastic carcinoma as well as in papillodes tumor. It will be negative, but in sarcomas. So if it is negative, you should consider some sarcomas. Now the previous case you saw osteoid, you saw chondroid areas, right? If we wouldn't have got any epithelial component, right? Any epithelial component, will you call it a sarcoma, primary sarcoma? Will you call it primary osteosarcoma of breast? It's quite possible. It's quite possible, although it's very, very rare. Anything which, if it's not showing any epithelial differentiation at all, then it should behave like a sarcoma, right?
Yes.
So if you don't see any epithelial differentiation, don't see any epithelial cells at all on extensive sampling, if you don't see DCIS, it could be primary sarcoma of breast. So let's see here. A1A3 here nicely positive, TRPS1 nicely positive. This was metaplastic sarcomatoid carcinoma. This is one type of metaplastic carcinoma. What about this? Another case. Pooja, haven't heard from you for a while. Do you hear me? What do you see here? Harshita, Sarita.
Squamoid cells are there.
Squamous
Okay,
differentiation.
squamous cells. And these?
Spindle cells.
Maybe spindle cells or glandular. What do you think it is then? Metaplastic squamous cell carcinoma. P40 nicely positive in some majority of the cells, but there are negative cells which are glandular cells. You can see nice desmosomes here, right? Keratinization and desmosome. So this is another type of metaplastic carcinoma. So coming to mesenchymal tumors of breast, how do you approach them? It could be metaplastic carcinoma, malignant phyllodes tumor, primary or metastatic sarcoma, and another one is very rare but melanoma. We have gone through the different areas, like what are the characteristic features. Carcinoma, we see some epithelial differentiation. Markers can be positive. Other markers will be negative, these ones. For phyllodes, the epithelial component is benign and it can be in the form of compressed ducts. Sometimes it can show epithelial proliferation, but it is benign. For phyllodes, the stromal cells, the tumor cells, they can be positive for this marker, say 34 BCL2. It can be positive for TRPS1 also, rarely for cytokeratids. If it is negative for everything, and you have clear-cut features of primary sarcoma, like leiomyosarcoma, maybe sometimes more commonly it's angiosarcoma, then you do other markers, and as per the lineage, like you want to do ERG for angiosarcoma, you can do that. Melanoma, although rare, as you may see some pigment, and if everything is coming negative, we do throw some melanoma markers, H100, HMB45. So this would be helpful to rule out melanoma, even if it is a melanotic. Is that clear to all of you? So this is just I'm showing. This one is a metaplastic carcinoma at the top, and this is phyllodes tumor. You can see the benign looking ducts. So these are phyllodes tumor areas, malignant phyllodes tumor. So the top two are metaplastic, the bottom two are phyllodes tumor. Approach to diagnosis. How do we approach? First of all, look for in a core biopsy, look for epithelial differentiation, look for any presence of DCIS. If it is monophasic sarcomatoid, you don't see any epithelial differentiation, at least do some cytokeratins. Cytokeratin, pan-cytokeratin, EMA, everything can be done, and try to find out if it is positive. But focal epithelial differentiation does not rule out phyllodes tumor. If everything fails, you give differential diagnosis. If everything fails, it is sarcomatoid tumor, call it a differential diagnosis. It can be metaplastic carcinoma, it can be malignant phyllodes tumor, it can be primary sarcoma. Is that clear to all of you? Why it is significant in biopsy? So, see, biopsy may not show epithelial component, but excision specimen may show. All markers can be negative, that doesn't rule out metaplastic carcinoma. So these are the important reasons where we should be commenting in biopsy. At the end, why we have to differentiate between carcinoma and sarcoma and malignant phyllodes tumor. I have given this this therapy, tell me something. If I call it malignant phyllodes tumor versus metaplastic carcinoma versus sarcoma, what will be the excision type if it is a big tumor?
If it is phyllodes, only mastectomy is done. There
Right.
won't be lymph node excisions.
Correct, Sarita. Very good. So mastectomy without lymph node excision, unless the lymph nodes are suspicious. Does that mean phyllodes doesn't go to lymph nodes? Very, very rarely we have seen, very rare, very rare. But otherwise, if the lymph nodes are not suspicious, they will not remove it. For carcinoma and melanoma, they will definitely remove it. Sarcoma, again, unless if they are not suspicious, they will not remove it. But larger tumors, usually they undergo mastectomy. Is that clear to you? Any questions on this? Before I go to the last two cases, Ayushi, any comments and any comments from chairpersons?
I think
Seema, you
Dr.
want to
Renu
say
has raised her
something?
hand, madam.
Who?
Dr. Renu, I think, has a query.
Dr. Renu, can you go ahead with your query? Seema, would you like to comment if you're for phyllodes versus metaplastic?
Yeah, it is very important to differentiate because our treatment option will change. Our choice of therapy will change. The kind of surgery we want to do, that will also change. As one of the resident has highlighted, that if it's a phylloid, then there is no need for lymph node dissection unless and until there are suspicious lymph nodes.
Thank you, Seema.
I would just like to add here one point that, as madam said, that if you're not able to differentiate, give a differential and this thing. So many times in the core biopsy, you will not be able to differentiate, because if like no single IHC is very conclusive. Focal CK or A1 A3 here and there will not be also be conclusive. So it is many times in the core biopsy you will end up giving a differential only, but you can kind of change the order of differential depending on the morphological clues you have. You can give a suspicion of one over the other. You can favor one or the other, and it is not always that on a core biopsy you will be able to arrive at a diagnosis between these differentials.
Thank you, Ayushi. And are there any comments, moderators?
No, ma'am. I think all questions are very well explained. So, ma'am,
No,
we can
not from
continue
my
with
side.
it.
Yeah, Renu madam, please go ahead.
Any comments? I don't have any questions also.
Okay, fine. So I think I'll go for last two cases together. This is first one was a 42-year-old female presented with a lump in left breast, which was noticed 8 months ago, and this was a 2.5 centimeter Berard's 4A circumscribed oval mass in upper inner quadrant. And this is the biopsy. Who wants to volunteer? Is Harshita there? How many are remaining now? Harshita, Sarita,
Yes, ma'am.
Anthony, Pooja, Pimpy. One of you, please describe both the cases. One can prescribe one and other one can describe the other case. Anthony, you want to go ahead? What happened? इतना सन्नाटा क्यों है?
Ma'am, I'll
Harshita,
go
go ahead.
ahead, ma'am. Sections studied shows ducts showing a slit-like appearance on higher
So what do you
magnification.
see here? Here is some fatty tissue, right? And there is
Yes.
some kind of tumor, right? Higher magnification. Tell me, what do you see here?
Ducts are distorted to form slit-like and elongated cliffs, giving intracanalicular pattern.
Okay.
Stroma shows proliferation with fibrocollagenous stroma.
Okay, tell me one thing. So when you look at this kind of tumor, what are the characteristic features you see in stroma? Who wants to say? Anyone around?
We have to look for
Stroma.
the cellularity,
One is cellularity. Okay.
overgrowth,
Okay.
ATPia, and
What is
then
overgrowth?
ma'am, if we are not seeing any epithelial component in one lobe or field, we can call it as stromal overgrowth.
So here, do you want to call there is stromal overgrowth present?
No, ma'am, I can see epithelial component there.
Okay. So,
And
okay.
next is ATPia. stromal atypia, and then fourth would be mitosis.
So tell me something now. Do you think how will you describe this cellularity?
Hypocellular.
Hypocellular, or it's not really, the cellularity is mild, not really increased, right?
Yes, ma'am.
And what about the stromal cell atypia? Is there any atypia?
No atypia.
Mild atypia.
So one thing I want to find out, like point out that if you see that
False.
entire biopsy, nowhere you see increase in stromal cellularity, nowhere you see atypia. Do you see any mitosis anywhere?
No.
No, ma'am.
So what do you think it is then?
Fibroadenoma.
Anybody would like to differ from that? So Harshita called it fibroadenoma. Everyone agrees with that? Yes or no?
I mean,
Tell me,
biopsy, we can call
Sarita,
it,
Pimpy, Anthony. Yes.
In
we
biopsy,
can
we
call it
can't differentiate
fibroepithelial
fibroadenoma.
neoplasm favoring fibroadenoma.
Anything is fine. See, now in this case, I would say it is clear-cut fibroadenoma. It has kind of stromal, no stromal heterogeneity, no increase in stromal cellularity. You look at the clinical features. It is well circumscribed. It is small. We don't see any atypia. So here, either you call fibroepithelial, benign fibroepithelial neoplasm favor fibroadenoma, or you can clearly call it as fibroadenoma. Okay. I wouldn't call this phyllodes tumor. This is not yet phyllodes tumor. Okay. Let's go to the next case and then we'll discuss together. 61-year-old postmenopausal lady, right breast lump for 4 months, 6.5 centimeter mass, hypoechoic complex lesion, solid and focused cystic areas, adherent to probably adherent to underlying muscle, which we got a biopsy from that. Who was to describe? Sarita, Anthony.
I think Anthony, go ahead.
Go ahead, Anthony.
In this power, I can see mostly stroma in the course, ma'am. And then few
Only
epithelial.
stroma? Do you say something else?
Yes, ma'am. And leaf-like architecture at places, ma'am.
Exactly.
And then
This is
epithelial.
higher magnification, right?
Yes, ma'am. And here I'm seeing increased stromal cellularity, ma'am.
Right.
And also there is non-uniform stromal cellularity. And I can see some subepithelial condensation here at places.
Yeah, so non-uniform, hyper.
Hyper, ma'am, but not like, but I don't
Mainly
see any
hyper.
stromal. Yes, ma'am, but no stromal overgrowth anywhere. I'm seeing
Yeah.
epithelial component in every field. And also in higher power, I see mild atypia at places, ma'am. And also in the
Mild to moderate, I would say.
Okay, ma'am. And there are two mitosis that I saw in one of my hypo. Yeah, there one.
Here is one.
Yes, ma'am. Here also one mitosis.
So, what do you think it is?
Ma'am, phyllodes, but I would like to count all the mitosis before my final categorization. I would say as of now, benign.
Benign, you want to call directly?
Borderline.
So we can't, it's like benign versus borderline is difficult in this case, but looking now, again, what is important here is look at the clinical findings, okay? 4 months history. Then this is almost 6 centimeter mass. She is 61-year-old female. So with so much of cellularity, atypia, easily mitosis found. So what is so definitely you want to call it fibroadenoma versus phyllodes tumor. Tell me one thing. What do you want to say?
Phyllodes.
Phyllodes tumor.
It is
Right.
phyllodes.
Now our question is whether it is benign versus borderline versus malignant, right?
Yes, ma'am.
How will it differentiate between all this on core biopsy?
With mitotic count.
It's not only mitotic count.
And all,
there are multiple parameters. No, I do true.
Stromal
But now,
hyperplasia.
Stromal cellularity, stromal cell atypia. There is mitotic count. So on core biopsy, all of these are important. Somebody has pointed out malignant heterologous element. It's definitely, if it is present, then we are going to call it as malignant phyllodes tumor. Here we don't see anything. So again, we are back to square one. So Dr. Lira says it's at least borderline. So tell me, all residents, what do you think? Phyllodes tumor, what type of Phyllodes tumor you think this is?
Borderline versus malignant, given the
You
history.
can't decide. Anybody wants to call benign? Less likely.
4 months.
We would say at least borderline. So first one was correct, fibroadenoma. Second one we will call at least borderline type because mitosis were easily found. So what are the characteristics that helps us to differentiate between these tumors? So when we say fibroepithelial neoplasm, you know very well there are two major types like fibroadenoma, Phyllodes tumor, of which these are three categories, right? So this table summarizes, which is in WHO 5th edition as well. Now, first, most important is tumor border. Now tumor border will be well defined for fibroadenoma, benign PT, and borderline PT maybe. But in biopsy, you can't see the tumor border. So that is out. What we can look at is stromal cellularity. We can look at stromal cell atypia, mitotic activity. Now, again, mitotic activity, you have to go for 10 HPF. Can we count 10 HPF in core biopsy? Less likely. That's why it is difficult to differentiate between the two. Of course, if I see in a core biopsy, if I see one small core, I see 10 mitosis, I'm definitely going to call it as malignant Phyllodes. But if I see hardly 3, 4, 5, I may not be able to say it is benign, but definitely I'll put it in category of borderline. So you know, less than 5 is always benign. Can I use the same criteria in core biopsy? It is difficult, right? Because I can't measure, I can't count it in 10 fields. So you comment on this and we say at least benign, or cannot differentiate between benign and borderline, cannot differentiate between borderline and malignant. So this is how it's going to go. You may not be able to count all mitosis in 10 HPF because you may not have that much tissue at all. Definitely, if you have malignant heterologous component, if you have multiple mitosis with atypical mitosis, you will call it as malignant. No mitosis, you say favor benign, okay? But some mitosis are seen, you can't rule out borderline Phyllodes tumor. So with this, what are the challenges in diagnosis of fibroepithelial neoplasm in core needle biopsy? Age is not included. Distinguishing cellular fibroadenoma from benign Phyllodes tumor can be difficult, okay? And sometimes we say fibroepithelial neoplasm with increased stromal cellularity. So again, that can be a problem if it is a small tumor, a young lady, you don't want to call it as Phyllodes tumor right away. Excised tumor is necessary. Excised tumor has to be sampled extensively to make sure we are not looking at any Phyllodes tumor. We have to rule out Phyllodes tumor. Usual Phyllodes tumor can show non-heterogeneous or non-uniform or heterogeneous stroma. So sometimes you may get hypocellular stroma in the biopsy, and otherwise it may be borderline Phyllodes tumor, but biopsy may not be that representative. So these are the challenges you may feel, you may come across while diagnosis of Phyllodes tumor in biopsy. Useful clues are age of patient, size of tumor, radiological findings, and histological features. No, this was not excision Richa. We are looking at core needle biopsy. So histological features are like if you see malignant spindle cells, atypical mitosis, malignant heterologous component, then we can call it as malignant Phyllodes tumor. There is this nice article, how to approach or how to classify fibroepithelial lesion in breast core needle biopsy. It is freely available on internet. Please go through that because I think we are almost approaching 9:30, so I'm not going to go through the details of this article, but very nicely explained in this article. Anyone has any thoughts? This is our take-home message. You want to read that? You want to say something, Ayushi?
No, ma'am, I
Ma'am,
think
is it absolutely, I'm sorry, I should have raised my hand, but is it essential, absolutely essential to differentiate between benign phyllodes and fibroadenoma?
Sometimes we cannot, and we say that. We say benign fibroepithelial neoplasm.
No, I'm saying in general, both our treatment for both should be the same, right? And
No,
this lady is about 42.
I don't think so. See, in Phyllodes tumor, there has to be some color of benign breast tissue, some negative margins should be there, because we are looking at a very small sample. And phyllodes needs to be sampled, but fibroadenoma, many times they go for enucleation. So if you cannot differentiate, you better say that we cannot differentiate. They can take out a little bit more tissue. But if it is fibroadenoma, you're sure you can say fibroadenoma, they may go for enucleation. For benign phyllodes, we don't know, because
this lady was 42. That's why
yeah,
I'm asking. That
in
is
42, it's a small biopsy. If at all it shows some areas of phyllodes-like areas later on, we don't want to go for further. See, margins are essential for phyllodes tumor.
yeah.
It's not the enucleation. So if you cannot comment, please say no, cannot comment on that. Benign fibroepithelial neoplasm is good enough.
Right.
Do you have any comment, Ayushi?
Yeah, that's fine. Thank you.
Yeah, I think you have covered these phyllodes, all the points. I don't think there is any active query left in the chat box also. And Dr. Seema, if she would like to add anything.
Yeah, hi, nothing else to be added. I would like to stress that it is very important that we have to have a correlation between the clinical presentation, radiological finding, and the histopathological report. That correlation has to be made. And if there is any doubt, please discuss with your colleague before you finally make the diagnosis.
Thank you so much, Seema. You have been here for the last 2
Madam,
hours.
you have stayed for
I
last
know
2.5 hours, and you have actively taken part in all the discussions. Thank you so much.
and guiding us. Thank you
Ma'am,
so
it was
much.
very well covered session, and you have covered almost every spectrum of breast pathology, be it benign, be it malignant, be it microinvasive sarcomas. So everything is, and all the cases were very nicely presented, and you have dealt the nuances of breast pathology, and indeed it is very difficult. And I always say this, that it is a difficult job to be a pathologist, because to me everything looks blue and pink. And how do you differentiate between their rounded cells, angle, corner? I think it's very tough to make.
So I would also like to appreciate the students who have
Exactly.
taken part. And also, I would like to appreciate there are some people who have very nicely interacted with their queries in the chat box also. I think in particularly Preeti Chauhan, Richa Ranjan, they have continuously asked questions and kept us on our toes. So it is very important for a lot of other people who might be thinking of these questions but not asking. So very thankful to all the people who have taken part in the interaction.
So hearty congratulations
Thank you,
to
ma'am.
all
Thank you for wonderful
students.
sessions.
So I would like to congratulate all the residents for participating. The first step is committing and getting out of that inhibition and start talking in front of so many people around. And you have done that. You've done a good job. Of course, keep doing it. Keep discussing cases amongst your colleagues. That's how you learn. I thank all the chairpersons for their active participation, Dr. Seema, Dr. Renu. Thank moderators, all of you. And of course, Ruchi and our Center of Oncopathology, pillars of our Center of Oncopathology. Thank you very much. Of course, last and not the least, my colleague Ayushi. She saved me today. She covered most of it. So thank you so much, Ayushi.
I think, madam, both of us really enjoy our Jugalbandi in this session.
So, any questions?
No, ma'am. Ma'am, you have covered all the questions, and we are getting many thanks for the wonderful session that